dan tidak lupa kepada Bapak Ibu Dewan Pengawas, Direksi, Panitia HKN, dan Sivitas Hospitalia Rumah Sakit Umum Pusat Fatmawati. Puji syukur ya, marilah kita senantiasa panjatkan kehadirat Allah Subhanahu wa Ta'ala atas karunia-Nya sehingga kita mendapatkan kesempatan untuk meningkatkan ilmu dan pengetahuan melalui acara International Seminar on Spine and Hip Management Update pada pagi hari ini. Seminar ini dilaksanakan oleh Rumah Sakit Fatmawati sebagai rangkaian kegiatan memperingati Hari Kesehatan Nasional ke-59 tahun 2023 ini. Kami ucapkan selamat datang di acara seminar ini dan kami sangat memberikan apresiasi dan ucapan terima kasih kepada Bapak Menteri Kesehatan beserta seluruh jajaran Kemkes, para pembicara, moderator, dan khususnya para peserta seminar ya, yang betul-betul telah memberikan perhatian, dukungan, dan partisipasi dalam kegiatan acara ilmiah ini. Rumah Sakit Fatmawati telah ditetapkan oleh Kementerian Kesehatan sebagai rumah sakit rujukan dan pusat layanan ortopedi nasional. Nah, dalam rangka peringatan Hari Kesehatan ini, Rumah Sakit Fatmawati mengadakan seminar yang terkait dengan penanganan kasus-kasus spine dan hip yang tentu saja kita saat ini melihat kasus ini semakin banyak dan membutuhkan perhatian kita semua. Dan juga dalam seminar ini akan dilakukan juga pembahasan bersama tentang terapi dan rehabilitasi ya pasca operasi. Seminar ini merupakan komitmen ya Rumah Sakit Fatmawati dalam sharing ilmu, pengetahuan, dan pengalaman di bidang ortopedi dan rehabilitasi medik ya. Bapak Ibu sekalian yang kami hormati, kompleksitas pasien serta kasus ortopedi dan traumatologi yang sangat beragam, khususnya di bagian spine and hip, mengharuskan kita tenaga kesehatan, terutama dokter-dokter ortopedi dan yang terkait, untuk terus-menerus mengembangkan diri. Terlebih lagi tingginya tuntutan masyarakat terhadap pelayanan kesehatan di bidang ortopedi dan traumatologi ini yang prima dan memuaskan. Pengembangan sumber daya manusia meliputi pengetahuan dan keahlian yang terkini, serta kemampuan menerapkan teknologi maupun teknik-teknik terbaru yang paling efektif dalam memberikan pelayanan terhadap pasien, sehingga meningkatkan angka kesembuhan dan kepuasan pasien serta mengurangi komplikasi yang mungkin terjadi. Nah, seminar ini juga akan memberikan sharingnya ya, bagaimana pengalaman-pengalaman para pembicara yang betul-betul kompeten itu dapat di-sharing kepada kita semua yang ada di Indonesia. Nah, seminar ini mengangkat topik spine and hip yang mencakup satu, preoperative optimization and orthopedic surgery. Yang kedua, update hip surgery and arthroscopy. Yang ketiga adalah rehabilitation management of scoliosis. Alhamdulillah, narasumber yang berhasil kita hadirkan itu betul-betul yang kompeten dan terkenal, ya. Sehingga seminar ini betul-betul memberikan nilai yang baik kepada kita dalam rangkaian HKN ini. Adapun narasumber dari luar negeri yang berhasil kita hubungi dan berkenan bergabung kita adalah yang pertama Profesor Mark Weidenbaum ya dari Columbia University Irving Medical Center. Yang kedua adalah Profesor John O'Donnell dari Australian Hip Arthroscopy Society. Welcome, Prof. Mark from Columbia University and Prof. John O'Donnell from Australia in this seminar. We are very happy to join and hear about sharing your knowledge and experience with doctors in Indonesia. Selanjutnya, alhamdulillah juga kita berhasil menghadirkan ya pembicara yang betul-betul juga saat ini mempunyai kompetensi yang luar biasa di bidang ortopedi. Ada 4 orang yang kita hadirkan. Yang pertama adalah Dr. Irfan Saleh, ya. Ini ortopedi dari RSCM, Fakultas Kedokteran. Terima kasih, Dok, telah bergabung. Kemudian Dr. Didi Librianto, ini SPOT juga dari Fatmawati, Dr. Jamot Silitonga, dan Dr. Yosi Pratamajaya dari ortopedi Fatmawati. Dan ada 2 orang narasumber yang berkaitan dengan rehabilitasi medik yang berkaitan dengan ortopedi ini pasca operasi. Yang pertama adalah Dr. Krista Andriana Tenges, yaitu spesialis rehabilitasi medik. Kemudian Dr. Sinta Diwiana, ini juga dari rehabilitasi medik, di mana kombinasi antara speaker dari luar negeri, dalam negeri, apakah itu ortopedi maupun rehabilitasi medik ini akan memberikan pengayaan bagaimana kita menangani spine and hip di Indonesia ini. Mudah-mudahan dengan seminar ini yang merupakan komitmen Rumah Sakit Fatmawati dapat menjadi kontribusi kita di Hari Kesehatan Nasional ini. Demikian, semoga Allah Subhanahu wa Ta'ala senantiasa memberikan kemanfaatan kegiatan seminar ini untuk kita semua. Dengan mengucap Bismillahirrahmanirrahim, seminar internasional, ya, International Seminar on Spine and Hip Management Update ini dengan resmi saya nyatakan dibuka. Dan terima kasih sekali lagi kepada seluruh pembicara, kemudian moderator dan peserta, dan khususnya kepada Bapak Menteri Kesehatan dan seluruh jajaran Kementerian Kesehatan yang telah memberikan kesempatan dan support terhadap kegiatan acara ini. Demikian, billahi taufiq wal hidayah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Terima kasih kepada Bapak Dr. Muhammad Syahril telah membuka acara ini. Dan sambutan berikutnya adalah keynote speech dari Menteri Kesehatan Republik Indonesia, Bapak Insinyur Budi Gunadi Sadikin, CHFC CLU. Namun karena beliau berhalangan hadir, maka marilah bersama-sama kita saksikan video sambutan beliau.
Kompleksitas kasus ortopedi dan traumatologi sangatlah beragam. Salah satu di antaranya adalah skoliosis, yang merupakan kelainan tulang belakang dengan kelengkungan punggung menyerupai huruf S atau C, yang sering ditemukan pada anak remaja, serta menyebabkan disabilitas fungsional maupun kosmetik. WHO mencatat sedikitnya 3% populasi manusia di dunia rentan terhadap skoliosis. Di Indonesia, prevalensi skoliosis mencapai 3 hingga 5% dari jumlah populasi, atau lebih dari 13 juta orang. Berbagai kasus ortopedi dan traumatologi yang kompleks mengharuskan tenaga kesehatan untuk terus mengikuti perkembangan ilmu agar dapat memberikan pelayanan yang berkualitas kepada pasien. Peringatan Hari Kesehatan Nasional tanggal 12 November memberikan kesempatan peningkatan keilmuan dan kapasitas tenaga kesehatan melalui berbagai kegiatan ilmiah. Melalui seminar ini, saya mengajak seluruh praktisi di bidang ortopedi dan traumatologi, serta seluruh peserta seminar untuk selalu memperbarui ilmu dan keterampilan demi memberikan pelayanan kesehatan terbaik bagi pasien. Akhir kata, saya ucapkan selamat Hari Kesehatan Nasional dan selamat mengikuti seminar ini. Semoga ilmu yang diperoleh bermanfaat untuk kesehatan masyarakat Indonesia.
Baik, demikian video sambutan dari Bapak Menteri Kesehatan Republik Indonesia. Dan berikutnya kita akan masuk ke acara inti, yaitu seminar ilmiah dan juga diskusi bersama dengan moderator dan narasumber. Secara umum akan terdiri dari dua sesi utama, yaitu topik spine dan topik hip dengan narasumber dari ortopedi dan juga dari rehabilitasi medik. Sesi pertama adalah topik spine dengan pembicara Prof. Mark Weidenbaum dari Columbia University New York. Dan pada sesi ini juga akan dihadiri oleh Dr. Ifran Saleh SPOT Konsultan selaku invited moderator atau panelis, dan dimoderatori oleh Dr. Didik Librianto SPOT Konsultan. Kepada Dr. Didik, kami persilakan bisa ke depan panggung. Izinkan saya untuk sedikit membacakan CV beliau. Dr. Didik Librianto SPOT Konsultan menyelesaikan pendidikan dokter pada tahun 2006, kemudian melanjutkan pendidikan subspesialis spine pada tahun 2008, dan beliau saat ini merupakan member dari Medical Club Society, AOS, Scholarship Research Society, dan juga merupakan Komite Konservatif SRS 2018 sampai 2019. Dan beliau juga merupakan Kepala Divisi Tulang Belakang di SMF Ortopedi dan Traumatologi Rumah Sakit Fatmawati Jakarta. Kepada Dr. Didik, waktu dan tempat kami persilahkan.
Ya, teman-teman, and also Dr. Mark, how are you?
I'm okay. Can you hear me?
Yes, very clear. And also Dr.
Can you see
Ifran.
me?
Yes, I can see you. And also
I have my screen shared, so I'm not seeing, but I'm hearing. So I don't want to touch anything because I don't want to mess it up.
Okay.
Dr. Ifran, how are you today?
Fine. Thank you, Dr. Didik.
So, please, CP, Dr. Here's CP or Dr. Mark. His birth is in Corning, New York. A lot of CV. Next slide. Directly to the, nowadays is a professional organization, is member of a lot of member organization, Dr. Mark. I cannot mention one of it. And also he's a professor in his hospital, director of orthopedic spine surgery in 1994 in 2015. Also, he is nowadays attending surgeon in New York Presbyterian Hospital, New York City. Thank you, Dr. Mark, for your attendance. We are very happy, and this is all the honors, grant, teaching presentation. In the left side, we can see his first coming to Indonesia in 2016, when there is first international spinal deformity meeting in Indonesia, in Bali. Next slide. Next slide. Okay. Then, please, Dr. Ifran Sifi. Yes, Dr. Ifran is he's a spine surgeon, chief spine surgeon in Cipto Mangunkusumo Hospital. He's a lot of member, lot of CV. He graduated in 1982. He's my teacher. Okay, next slide. Previously, he is Indonesian Orthopedic Association chairman. Okay, thank you. Okay, Dr. Max, and now you can start your presentation. Please.
Thank you so much, Didik. And before I begin, first I would like to thank the organizing committee and Didik and Ifran for this wonderful invitation. As Didik mentioned, I first came in 2016, and I've been to your beautiful country several times, and I'm so grateful and thankful for this experience and this opportunity to meet such wonderful people. I can tell you that These two surgeons, Drs. Saleh and Librianto, are fantastic surgeons. They're respected around the world, and you're lucky to have them, and I'm happy to know them. Thank you very much for this. So let me begin, and the title is Preoperative Optimization for Spine Surgery. So I asked Didik, what was the composition of the audience? In other words, are most people doing spine surgery? Are most people doing something else? And he indicated that a fair number of you are doing spine surgery, which is wonderful. But there are also some who are not. So I tried to make this talk understandable to both. And at the end, I hope you'll understand why I chose this topic. I don't have any relevant disclosures for this. So let's jump in. This is a case, straightforward, nothing fancy, 15-year-old with a 54-degree scoliosis, which gets operated, not a big deal, pretty straightforward, not perfect, obviously, a little bit translated, but really not bad. And just so that's clear, this is not my case. This is my wonderful young partner, Zishan Sardar, who did this case. And I just want to give him a little credit and also to show his case. And another case of his, another relatively simple case, 16-year-old boy with a 56-degree curve. And you can see that it has been considerably corrected from 56 degrees, the middle number here from T6 to L1. And this has been corrected to 17 degrees, and everything looks pretty good. Okay.
Mark, sorry, your screen is not clear here.
My screen is not, I'm sorry?
Your slide is not in the screen.
Oh, it's not in the screen?
Yeah, your slide.
You do not see the slides?
Yes.
Yes, you do, or yes, you do not?
Not. I just saw your face.
One moment. Let me end this and I'll start again. I thought it was sharing. 1 second. Where is the Zoom? We had this all going. I see my face here. Let's share screen again. Share screen. Thank you for telling me. I thought it was sharing.
Okay, now you're clear. See your slide. Thank you, Max.
Thank you very much. So this was the first slide. Did people see this slide or no?
Yes, I saw your slide.
Okay. So that was the first slide, and then that's Zishan, and this is another case I just mentioned, very straightforward, nothing too fancy. But what about this case? 48-year-old woman, a history of adolescent idiopathic scoliosis. She had surgery, posterior spine instrumentation infusion, when she was in her late 20s. And now here she is, 9 operations, 9 surgeries. And after the last one, worse than ever before, obviously leaning forward, terrible pain, on narcotics, the bone quality is not so good, and a history of infection. She neurologically is okay, but she really doesn't walk very well. This is completely different from the healthy adolescent child, which we all love to talk about because it's relatively simple. So how do we deal with these problems? And as I'm sure many of you know, we, in order to correct this type of curvature, need to perform what's called an osteotomy. An osteotomy means cutting the bone. And so there are different ways to cut the bone for spine surgery. It can be a relatively small cut, which we call a posterior column osteotomy. It could be a medium-sized cut, which we call a pedicle subtraction osteotomy. And it could be a big cut, which is a vertebral column resection. This has been discussed in the literature. There are many articles about this, but again, I realize that not everybody in the audience is a spine surgeon. But look at this right here. Complication rate, 69, almost 70%. That's crazy. That's really crazy. And you know what? That's honest. So when we try to do these osteotomies, in the old days, we separated it into those three. Now we use Frank Schwab's classification, which many of you probably are familiar with. I won't go through it in detail because it doesn't matter for the purposes of this discussion. But it basically, there's 6 types of osteotomies going from very small to very big. And you select the osteotomy based on the severity of the curve and by many factors. So when we decide which osteotomy are we going to use, we look at what type of curvature is it? Is it a scoliosis only? Is it a kyphosis only? Is it both? Is the curve very stiff? Is it very smooth? And what about the spinal cord itself? I'll show you some examples. And we try to figure out what is going to be the best way to get this person balanced in the coronal, that's the front view, and in the sagittal, the side view. And obviously, a lot of what you decide to do as a surgeon has to do with your own personal level of comfort. What's your training? What's your experience? What do you think? And obviously, the big thing here for all of us is safety, safety, safety. I tell the patient, the number one concern we have as surgeons is patient safety. The number 2 concern we have for patients is patient safety. And the number 20 concern we have for patients is patient safety, because we all know that that is what patients are worried about. So given the complexity of these different kinds of osteotomies, is a 3-column osteotomy really necessary? So I mentioned flexibility. There are many measurements for this, and I won't bore you with that. We look at comparing standing films to lying down or supine x-rays. You can sometimes use the SCOUT from a CAT scan. There are hyperextension, flexion, blah, 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 and much has been written about this. There's another entity which is called the deformity angular ratio, DAR, and this refers to how sharp is the curve. In other words, if you take the Cobb angle, the total Cobb angle, and divide that by the number of levels, you get an idea of how sharp it is. A very smooth curve is, much easier to deal with a very short, sharp curve. And so there are, again, numbers for this. I won't bore you with it. I'm just bringing it up as one of the reasons why I'm giving this talk. I also mentioned the spinal cord itself, and you can classify the spinal cord into one of 3 types. One is where the spinal cord is not in contact with the spinal canal, the wall. 2 is where the cord is just touching it. And 3 is where the cord is really deformed or stretched or pulled over that. And if you look at the numbers here, the odds, the chance of having a neurologic problem after surgery when it's a type 1 cord is very, very small. The chances of having a problem in the middle one is significantly higher, but it's still very low. But look at that number, 28. When the cord is deformed, it really changes things. And so it's not just the Cobb angle. It's not just how flexible the curve is. It's not just the location of the curve. It's also how sharp it is and the position of the spinal cord inside. So when we're facing a problem like this, a patient with a large curvature here, 120 degrees. We do bending exercises and we come up with all kinds of information and data about how big the curve is, how much is it correct, what do we think, etc. This is how we make our surgical plan. But we know there is danger. So as some of you know, we use a device called a pedicle screw, and some of you have done thousands of these, and others probably have done none. A pedicle screw is a screw that we place because it gives us tremendous power, tremendous security, tremendous grip, tremendous purchase on the spine, so we can do what we want with it. And this is a diagram of where we place these screws, and this is called anatomical placement. In other words, the surgeon uses anatomy to decide where to place the screw. And this is a model where you might be able to look at the red dot, be about where you would try to start placing your screw. And then there are many articles written about this, how to get the screw in, and you want to get into this part of the vertebra, which is the pedicle, which is the strongest part of the vertebra. And obviously you want to avoid the spinal canal. So there are various tools for this. And many of us have done many of these and are very comfortable. Others are not so comfortable. It really depends a great deal on your own personal experience. But most screws today are put in, quote, freehand, meaning you put it in by anatomy, or maybe use the fluoro or something intraoperatively to guide you. Now, one of the things that can happen is you can have the screw go in the wrong place. And so this would be an example of good position for the screw. Here, the screw you can see is just kind of on the edge of the spinal canal. Here, you could see that it's getting closer, and now it's in the canal. And obviously, I mean, these are not fortunately, they're not my x-rays for my patients, but you can see that this screw is okay. This is lumbar. This one's in the canal. This one is bad, and this is a disaster. And obviously, nobody wants this, and we do everything possible to avoid this. Which brings us to the issue of navigation and robotics, which has been very popularized, and many hospitals are considering buying them. They're very expensive. And obviously, the hope is that this will make our surgeries safer. And so there are some that are what we call navigation. And again, some of you may have experience with navigation, others may not. And it's very much like a GPS, like you have in your car or you have on your phone. And it helps to guide you as to where to place your screw, and there are various techniques for this. Another option is a robot, and a robot is different from navigation. And the software and the technique is really quite different. But again, the hope is you can plan, you can decide where to place everything, and it makes the revisions easier and is less danger. And of course, it hopefully reduces the amount of x-ray that you get in the surgery. And hopefully you can plan things like, where am I going to place my screws? Here you can see from the robot, it's giving you the robot software is giving you this information. It's using a preoperative CAT scan, and then it embeds that into the preoperative CAT scan. And again, there are many different types of robots these days, and you hopefully can decide exactly how long should your screw be, what angle, depending on the vertebra. And then today, we typically, after placing screws, will get an intraoperative axial imaging study, an O-arm or something, but many hospitals do not have an O-arm, and so you still have to have a level of comfort in order to do these techniques. So if you have, for example, a revision, and this is a simple case, you can see the screw is out the front here, like what angle should I go in, etc. So there is a lot of interest today in the robot, and there are pros and cons, things that are good and things that are bad. The advantage is hopefully it's accurate. Hopefully it's safe. I'll talk about that in a minute. It gives you the chance to look at the spine three-dimensionally, and that's very helpful for teaching medical students, teaching residents, teaching fellows. It helps you to plan where you're going to make your osteotomies, and it's hopefully going to be good for severe deformities. Now, we started using the robot on simple cases, no deformity, just to become accustomed to it and used to it. It's like learning how to use your GPS. If you drive home from work, you don't need a GPS, but if you are trying to learn how to use your GPS, you would use it to drive home. And obviously you understand that analogy. The problem with robots are they're very expensive, and they force the surgeon to trust it. And this sometimes feels blind, and it is very scary. And when you don't know for sure whether it's accurate, it's a very scary feeling. The other thing is that very often when you use the robot, you lose what we call the haptic. The haptic is the feel, like, is the bone hard? Is it soft? Does it feel right? Does it, that sensation that you have as a trained surgeon? Yeah, that feels like a good screw, or no, I think that one's out. And you don't get that with the robot. The robot also takes longer in most cases, and it affects how long the operation takes. And there are lots and lots of issues, technical issues, not only with the registration, but software updates and changes, new models, etc. So I would just say that the robot is not what you necessarily what you think it is. Interesting article here from a couple of years ago. Computer-assisted navigation is associated with an increased risk of neurological complications. This is in lumbar cases. And you can see the numbers over here. Now, you would think that the number would be lower. That's why we use it. But as my friend Izzy Lieberman says, a fool with a tool is still a fool. You have to be very, very careful with this and be very, very certain that you can trust it. And so we today in my hospital we do not use this for high thoracic cases because we have had several cases where the robot said, go here, and we went there, and the patient had a neurologic complication. And we never would have put the screw there, never, freehand or just with fluoro. And it was because of a registration error, somebody bumped the table, something moved, or something like that. And it's very, very frightening when that happens. So we use it for lumbar or very low thoracic because there's more room in the cord, in the canal, but high thoracic, we are afraid to use it. Anyway, in general, adult spine deformity, which is my focus, we know, all of us know who do it. It's very, very difficult. They're big surgeries. They're three-dimensional. Patients are older. Patients have many other medical problems. You have to decompress, and a lot of patients are not in very good condition. And so we again know that there are a lot of complications with this. 64% here from a recent article from a couple of years ago from Serena Hu's group in San Francisco or Stanford. And look at these numbers here. This is, do you really want to do this operation? And yet we know that we have to. Cases are big. Sometimes they're going on for many hours, a lot of blood loss. And I think you can understand and recognize all of the issues that I'm listing here. You only have to have one of these to never forget it. And, a bad infection, a bad PJK like you see on the right. We all have to face these things. And again, the question is, how can we avoid this? Deep vein thrombosis, intravascular coagulopathy, medical comorbidities, etc. So how can we improve this? Well, thought about this started a few years ago, and Farhan Paliz wrote this nice article here, developing and validating risk stratification models for adult deformity surgery. And this is not easy. I'll just leave it at that. I don't want to take up too much time with this. Big study, ISSG, ESSG. But we try to look at this in a very simple way. The big challenge today is patients are older, they're sicker. We have more technology available, some of which is very expensive. Patients also have more medical problems. As I say, in the old days, people died younger. Now people live forever and their parts wear out, and we are dealing with that. And so how do we get this patient optimized so that we know there's risk in doing the surgery, not the pediatric simple one, the complicated adult one, and some complicated pediatric ones, et cetera. And the other thing is this. A lot of patients come in this way and they expect to wake up like this. They expect to be 20 years old when they wake up. And the expectations, I mean, it's obviously an exaggeration, but people have very high demands and expectations. So we have a changing demographic. People are definitely older than they used to be. Our hospital belongs to a group of 5 hospitals that all share the same malpractice insurance company. This malpractice insurance company came to our 5 hospitals and took a group of spine surgeons and said, okay, we know that a lot of these patients are having problems. We're getting lawsuits from this. It's costing us a lot of money. What do you surgeons think would be the best thing that you could do to try to reduce the risks and the problems? Anything that you could think of. And so people thought of all these things, having a dedicated team. Wouldn't that be nice? The same nurse, the same scrub tech, the same anesthesia, teaching the patients more clearly, having better guidelines, better communication, teaching the residents, better anesthesia, stratifying risk, having a conference maybe, better postoperative care. Each and every one of these things is something which has merit and is important to do. Well, guess what? Which one won? Which one was the one that the most people voted for? You guessed it, this one. It's to have a dedicated time in the month when we can talk about difficult patients, because difficult patients really require a lot of thinking ahead of time. So it gets to the question of who decides when the patient is optimized. In other words, is it the surgeon? Is it the medical doctor? Who of these people that you see here? Maybe it's the social services person. Maybe they need to have a place to live. Maybe they need to have a mother to go back to, or a husband that will take care of them, or, you know, these things. But we need to figure out what is the best thing for this person. They're not just an X-ray. And very important is to remember that medically cleared does not mean medically optimized. Optimized means you've made this person as good as they can possibly be. You may not be able to change how old they are, but you can maybe make their diabetes better controlled, their cardiac condition better controlled, etc. And sometimes when you get medical clearance, it's not worth the paper it's written on, because the minute you touch that patient, they have a bad complication, and they weren't really optimized. They were cleared by someone who didn't really care, or someone who didn't understand what it is that you were going to do with that patient. So when should you decide when they're cleared or optimized? And should it be months, weeks, days, the night before, etc.? You can argue about this. And more importantly, where is the decision made? Do you talk about it in your office? Do you have a conference? Do you discuss it with your friends in the hallway? Oh, I'll talk. And we know that we surgeons have almost no interest in learning details about the medical comorbidities. That's why I put, it's like having our teeth pulled, or we can't fall, we fall asleep. We find it boring. No one wants to talk about it. I'm too busy. My schedule's tight. We didn't do this the last time. Why do we have to bother with this? And then the other question is how? How do you decide? How do you decide what patient is really ready to go? And so we looked at the literature, and there are a couple of not very good metrics, and we came up with our own. So this is called a risk stratification metric, a spine screening calculator. And we look at the obvious things. Age, if you're under 60, it's 0 points. If you're over 80, it's 3 points. If you're heavy, if you're the normal weight, you're good. But if you're too heavy or you're too skinny, that's higher numbers. Is this a revision operation? Do you use nicotine products? Are you diabetic? And you can predict almost all of this. Do you use narcotics? We ask about depression, anxiety, bipolar, schizophrenia. You have to ask about these things. Have you had a heart attack, bypass, blood pressure, CHF, atrial fibrillation or flutter, DVT? And we come up with a score, which we call the complexity score. And it's either green, yellow, or red, just like a traffic light. So if you're green, it means your score is less than 10. You're basically pretty healthy, pretty good to go. If you're red, it means wait, stop. Maybe we shouldn't do this operation. There are too many risk factors. So the yellow is the area where we think we have the greatest opportunity to make a difference. If we take somebody that we identify as being at risk, then maybe we can optimize them, get their diabetes, get their cardiac status better controlled, maybe not do the operation that we thought we were going to do. And so we use this risk stratification tool to come up with these scores. But within that, there are several things which are a hard stop. We will not do the operation unless this specific issue is first addressed. High hemoglobin A1C, no one can smoke no one's getting operated if they smoke, period, none. And all these other things here. And then we have a conference. This is what people really wanted. A schedule. So what happens is we have a guy that you see over here, Eric. Every case that gets scheduled, Eric looks at, and he goes through the chart, and he comes up with a number, and he decides whether it's green, yellow, or red. He then makes a list of the yellow or red cases, and we talk about them in a monthly meeting. And that meeting has to be at least a few weeks before the operation. And who's at the meeting? It's not only the surgeons, it's also other people, anesthesia, medicine, critical care, and the attending surgeon has to come. It's not just for the fellow or the resident. The attending surgeon has to be present or the case gets canceled. One of the questions is what time of day do we do it? We prefer 6 a.m., no medical people will come at 6 a.m. So we moved it to 7. Now we have trouble getting anesthesia to come, but we're trying to figure that out. That's actually an important point. So quickly, the results we looked at over the course of a year, 273 patients with a score over 10. 85 of these were presented. Like I said, we can't show all of them. And then 188 were not. The ones that were presented were the ones that had the higher score. Now look at this number. 91% of these patients, 91% of them benefited from the conference in that something was suggested. Half the patients, 51%, required additional medical clearance, and that's how it's broken down. 13% of cases were canceled because everybody agreed, no, we can't do this now. So here are some of the simple examples of things that people found: changing medication, respiratory therapy, pacemaker interrogation, stopping smoking, figuring out cardiac meds because they had a long QTC interval, et cetera. You can imagine what would come up with this, but we have to do it really as a group. And so it's still a high number, but at the end of the day, the complication rates, when we looked at people who were discussed in the conference, the preoperative optimization conference, with a score of greater, when they were presented, the complication rate was still 43%, but the ones who were not discussed were 67%. Now, those are high numbers, but they're honest numbers. And so we're trying to figure out, how do we reduce complications in these risky patients? We can't change the magnitude of the surgery in general, but we know that it does help. And Raj Sethi, who's been a leader in this, has shown an 80% drop in legal action once they started this type of conference. And I think they started about 10 years ago. We started a few years ago. And let me just finish on this point here. Our systems are too complex. Look at that list of stuff on the right the surgeon is thinking about. That's a lot to think about. They're too complicated to be 100% perfect all the time. We have a responsibility to be safe. And we know that problems arise. We know that mistakes are made. We know that mistakes are made. We know that mistakes are made. And 70 to 80% of the time, it's some kind of a communication error. And look at this right here. More than half the time, somebody in the OR knows that it's the wrong procedure, wrong side, wrong level, and they don't say anything about it. I know if I'm operating and somebody realizes I'm making a mistake, I wish that they would tell me. So let's just spend a second on this. Why is it so safe to fly in a commercial airplane? One crash for every 11 million flights. What makes it so safe? Is it the design of the airplane, the FAA in the United States, maintenance, training, simulators, all these things? Is it checklists? No. Commercial aviation is safe because every person, no matter how junior or senior, is encouraged and empowered to speak up without fear of punishment, embarrassment, or retribution if they are wrong. And we need to do this. Here's an example. You may remember this Asiana crash 2013, brand new airplane coming into San Francisco. I think it was perfect weather, experienced captain. This is where the airplane should have been. This is where it was. And this is what happened. What happened? The co-pilot knew the captain was wrong. But in his culture, he didn't feel it was right for him to say anything. And this is what happened. A simple example of you should say something and not fear something bad will happen to you. So we need to empower, enable our OR staff, the orderlies, the techs, the nurses, the aides, the residents, the fellows, the visitors, everybody to be able to say, wait, that doesn't look right. And if they're wrong, no problem. Thank you for paying attention. So we believe that not only do we surgeons need to think medically and involve our non-surgical colleagues, but non-surgeons need to think and understand better what we do. And so our hope is that as this moves forward, the culture will change in our hospital, and it has already. People look forward to coming to this meeting because they know that they can show their dirty laundry, and they know they can talk about problems in a deep, honest way, and everybody is going to listen to them. So anyway, I'm sure I went over my allocated time, and I apologize for that. But I do feel very strongly this is such an important thing. Here, obviously, it's about spine surgery, but you could obviously use this for any other type of major orthopedic surgery or even other types of surgery. Thank you very much for this opportunity. And I would just say, terima kasih.
Fran, please.
Thank you much, Mark, for a very excellent and very nice lecture. I think now we all should knowing about how difficult and how more complex being to do the spinal surgery. I think we open for discussion. Any comment or question? Thank you, Mark, for very nice lecture.
Yes.
Thank you for
please.
the opportunity.
Is there is any question from the audience, please?
I think this one question from the chat. I will read that. There is a very unhappy situation and every surgeon fears meeting with it. The 3D navigation system are more exact, but also here screw misplacement are possible. The literature present data for below 1%. In square surgery, the misplacement is more probable because of the altered pedicle anatomy. Similar cases are rarely reported, sometimes because of the very unpleasant personal drama of surgeon and patient. What is your experience or information about similar case?
Well, I think that one of the big problems with using both navigation and robot with big deformity is that the pedicle itself is, as you know, is sometimes deformed, and it's also very sclerotic, very hard. And so you can start in the right direction, but it's very easy for the drill to kind of just go a little bit off because it's maybe you have to burr down first and make it, so that you may start correctly, but you don't finish correctly. And I think that in the cases that we had in our hospital, that's what happened, that they had very sclerotic pedicles. And it's just, a small error in the beginning of putting the pedicle screw in results in a significant error where it ends up. I say to the residents, a small navigation, if you're flying from New York to London, or let's say from Jakarta to New York, a small navigational error when you leave Jakarta is a big error when you get to New York. So it's the same thing.
Okay, I think we don't trust 100% to the
Yes.
robot or navigation. I think as a surgeon, we have to feeling how to put pedicle screw in the correct and accurate manner.
Absolutely. So important, especially for people in training. If people in training become dependent on a navigation or a robot to be able to do the surgery, what will they do when that machine breaks? And the other thing, you might laugh at this, is I don't know, I'm sorry, I don't know the geography of Indonesia well enough, but if you want to go from, say, Jakarta to Bali, you don't go from Jakarta to London to Bali. But if you put in your GPS and you just followed it, and you didn't know where Jakarta was and where London was and where Bali was, you would just follow it blindly. But it's wrong. So you have to understand the anatomy. You have to understand where you're going, why you're going there, etc. And if you don't get that in your training, you'll never get it. And you become a very dangerous surgeon. And we know that navigation, robotics, they're very good for marketing. They're very good for advertising. They're very good for making things look good to the patient, and patients ask for that. But, you got to be honest about it and say, wait a second, I don't want to, yes, it's good for some things, but maybe not for you, or something like that.
Okay, thank you, Mark, for your insight to our spine community here. Yeah, I think the more important as our feeling as a surgeon is you have to trust it. I think.
Sorry to interrupt. There is a direct question from the audience, please.
Yes, thank you, Dr. Ifran. Dr. Mark, thank you very much for the insight, for the great lecture. What I like to ask, your point about preoperative conference is really a great insight in making a better patient safety. So it would take a high commitment in very broad range of medication specialties. My question is, in starting this preoperative conference, do you have any problems in making this conference available to preoperatively? As we know that spine surgeries is one of the most high load surgeries, especially in Fatmawati. Do you have any problems in attending or have this meeting preoperatively, and how do you overcome that problem? Thank you, Doctor.
Thank you so much. That was a terrific question, and thanks for asking it. Everybody is busy. And, for example, we have a Monday morning conference where we discuss all the post-op cases and all the pre-op cases. And then on Wednesdays, every Monday at 6, we have a spine conference. And every Wednesday at 6 a.m., we have either a research conference, morbidity and mortality conference, some kind of a departmental conference. So everyone is busy. So this is another conference that we have to go to? Really? Isn't that like, come on. And so the thing is, there isn't enough time in any of those conferences to actually talk about somebody in a lot of detail. And so getting it started is the hardest part. What I would suggest you do is try to find what I call a champion, a medical doctor that you work with, that you like, that you trust, and tell them about it and ask them, would you be willing to talk about these 2 patients, these 4 patients, and let's figure out when. And then get somebody, if you can get somebody from anesthesia to do the same, to just start. And because people are going to find reasons to not come because they're going to be, I'm too busy, I don't have time for this and this and that. But when they see the value of it, it makes their life easier, because now, instead of wasting a lot of time taking care of a bad complication that you could have avoided, okay, it cost you a little time to go to conference and to prepare for conference, but now you avoided that DVT, you avoided that heart attack, you avoided that whole thing. And so I think people want to do this, they just don't know how to do it, and they need some structure for that. And if you can give that to them, we're going to meet here at this time to discuss these patients, to discuss these issues, and do the work ahead of time so that you know what their glucose is, you know what their cardiogram is, you know what their medical condition is, so that it's not a waste of time for people. I believe that you'll be able to plant a seed and have it grow. Great question.
Any more questions from the audience? Hey, Mark, I want to ask you how you trick when you get the difficult case. I mean, difficult, that means a lot of the complication, or maybe the patient with the like your rep area. How you trick and to do this case? You just refuse to do surgery, or maybe you have to try to a little bit manipulate. How you trick about this?
Another great question. So the big problem is that if we go through all this and we say the patient is red and we refuse to do it, they'll just go across the street to another hospital and they'll do it because it's a case. And, so, we are trying to, we don't refuse every red case. We don't. We try to explain to the patient, and we try to do the very best we can to get the person and have the family involved, have the other doctors involved to explain the situation. But there are times when we will refuse to do it. We will explain everything to the patient in detail about why we're worried they're going to die. We're worried they're going to be worse for whatever reason. And we tell them, we know that you could just go down the street to another hospital and someone will operate on you. And I say to them, if you are my mother, if you are my brother, if you are my uncle, I would not want you to do that because of all these reasons. It's a free country. People can do what they want. And all we can do is do the best that we believe in. But eventually, surprisingly, most of the time, unless the person is really, as we say, special, they'll listen. I'm sure that there are times when we make a mistake and, maybe we're being a little bit too careful about it. But, I think we're better off we're pretty aggressive. We'll do some really big, bad cases that nobody else will do. We just want to try to do them as safely as possible.
Thank you, Dr. Prof. Mark. It's a great explanation. There is still a lot of questions from the audience. Please.
Yes, thank you very much for the opportunity. Thank you for the wonderful presentation, Professor Wedenbaum. I have two questions here. The first one is, you earlier mentioned about the DAR and cord deformity. My question is, how do they change our surgery and surgical preparation? And the second one is, what are the population of the preoperative conference study that you performed? Do you include all types of patients? And do you implement them in all kinds of spine surgery or only selection of cases? Thank you.
Thank you. So your first question about the DAR and cord, yes, they do affect what we do because it primarily determines what type of osteotomy to do. Whether or not you should do we do a lot more VCRs now than we used to, but it's very helpful in A, deciding the type of osteotomy, B, I think it also helps us to tell the patient what to expect. And we also will sometimes modify the protocol used by the neurological monitoring team when we know this is a very high cord risk as opposed to a more simple one. But it's primarily the osteotomy type. I don't know if that answers your question or not. Your second question, we take all spine cases, because you could have somebody, for example, who is 55 years old with a terrible spinal deformity, but relatively healthy, and they will end up green on that list. And you could have somebody coming with cervical surgery, and they had a prior stroke, they had a deep vein thrombosis, they've had, tuberculosis or something like that, and they end up being high yellow or almost red, and it's not that big of a surgery. And so we, in the case of the smaller surgery, the focus is on the medical clearance, and on the other surgeries, the focus might be, on the surgical side. In other words, if that 55-year-old with a large deformity was also very sick, had a prior stroke and blah blah blah, we might not. The person presenting the case might have said, "Oh, this is what I want to do," and we might say, "Well, wait a second. Don't be a hero. Yes, just do this. Don't do that." So we look at everybody regardless of their age and regardless of the size of the surgery. If it's all spine surgeries.
Thank you, Dr. Mark. Okay, there is also another question from the audience. Please.
Good morning, sir. Thank you for your very great lecture. I would have to ask one question. Sir, you mentioned that previously there are a spine screening calculator and also complexity score to define the risk of surgery, especially in spine surgery. Is it used only by the surgeon, the orthopedic surgeon, or also used by anesthesia, internist, and when there is a difference conclusion between the surgeon and internist or anesthesia, which would you follow, sir? Thank you, sir.
Thank you. I love that question. Most of the classifications that surgeons used are primarily used by surgeons. And I don't know about your hospital. It's a very well-known hospital, Fatmawati, and you do a lot of great work there. I'm sure some of you at the conference are in smaller hospitals where it may be a little bit different. And so, at the end of the day, when you start to do a big surgery, you want to know that you are able to trust the anesthesiologist and the medical doctor, and they need to know that they can trust you. If you tell them, oh, it's not a big case, and then it's a huge case, they know they can't trust you. And so you have to prove yourself to them first. And then that's number one. Number two is we try very, very hard to teach our medical colleagues and our anesthesia colleagues about these classifications so that we are all speaking the same language. And it sometimes takes a few months for that to happen. Depending, if you have the same anesthesiologist at every surgery, that's wonderful, but nobody has that. It's, you might have a team of, let's say, 7 or 8, and then, one goes on vacation and you don't know who you have. And so it takes a long time until, and maybe you never really have a team, but we're trying to establish a common language that's understandable, and it takes a long time. I mean, we started this. I started this a couple of years ago because I believed in it very much, and now everybody does it, and people look forward to it because they realize that it's good. But it's much slower uptake in the medical community and in the anesthesia community. I went to the chief of medicine in my hospital, and I tried to explain to her why I thought that was so important, and she was like, eh. But then once they started coming, she realized, I didn't really understand what you guys do. And they don't. They think a laminectomy is a T12 or a T1 to the pelvis. They don't understand the difference. And I don't blame them. We went to medical school. We learned about EKGs. We learned about fluid management, but they never learned about orthopedic surgery. And so it's not really it's not such a far stretch to realize why they don't understand. So it's our responsibility, A, to know they can trust us, B, to try to establish a common language, and C, to try to teach them, educate them, show them what it is that we're doing. And, it's a slow process, but once you have, as I mentioned before, a champion, they make it their own business. They're like, oh, that's really cool. And then they teach their other medical people about it.
Okay, thank you, Dr. Mark. Dr. Ifran?
Thank you, Dr. Mark, for your very, very good insight to us, also to our colleagues, and also our medical training and residents. And then I just want to ask you, when your expectation about the case, how we make the same level expectation between the patient and our as a surgeon, because sometimes the patient expectation is very high, and we try to catch up. Maybe how we make it more equal between we as a surgeon and patient as a customer.
Oh boy, today's society is, I say, we live in what I tell this to patients in the office. I say, we live in an instant fix society. You click on it, and then you get angry if Google doesn't load in 1 second because you instantly need it right now. And I tell them, this is not instant. This is going to take a long time. And so I spend time with them trying to explain that to them. I don't really know if it penetrates. I don't really know for sure if they understand. I think that one of the problems that we face in general, you might laugh at this, is that at least in the United States, when we talk to people who are facing spine surgery, and I'm saying this primarily not to you, but to the younger doctors on the Zoom here, is we use words that people do not understand. It's a vocabulary. They don't understand what it means, the word. We do, but they don't. And in addition to the word, we used concepts, bone healing, internal fixation. People have no idea what that means. And so they kind of, yeah, but they didn't really understand. And as an example, I use myself, and I say, 20 years ago, I went with my wife, we went to get what's called a will. A will is a piece of paper that says when you die, your children get your money or your house, and it says who gets what. Nobody was sick. Nobody was dying. It was just a simple thing that you should do. I don't know what the laws are like in Indonesia, but in the United States, a will is a good, W-I-L-L. It's a good thing to have. So we went to the lawyer. It's usually done by a lawyer. And I said to him, please use little words and cartoon diagrams to explain this to me. And he went to college and university. I went to college and university. He spoke English. I spoke English. He used what he thought were little words and simple diagrams. And at the end of the session, I had no idea what he said. And it wasn't that he didn't try, and it wasn't that I didn't try. It's just different. And I think that we need to understand that about our patients. And one of the problems that we have, and I know this is the American Academy of Orthopedic Surgery says this, NAS says this, SRS says this, is that the information that we give to patients needs to be at a level that could be understood by somebody who's 14 years old. If it's more than that, they're not going to understand it. So to your question, Fran, I don't know. I don't have a great answer for that. How to get the patient to have realistic expectations, try to explain and spend a little time with them and maybe have a personal relationship with them. But I've certainly failed on that on a number of occasions.
Yes, Mark, because nowadays, as you said, it's click, instant, yeah. They maybe have some information from the Google, yeah, and then he try to push us, yeah, to get what he want. Yeah. And sometimes, in our technical surgery, sometimes it's impossible to do that. Yeah. That's why it's very important to make the level expectation between us as a surgeon and patient as a customer. Yeah. Otherwise, they might be disappointed or unhappy after the surgery. Yeah.
Absolutely. For an example is, for example, minimally invasive surgery. So a lot of patients come and they, we talk, about surgery and this and that. And then they say, well, this is minimally invasive, right? And so and I say, well, minimally invasive sounds really good. It sounds really, like seductive. It's, small incision, less blood loss, quicker discharge, right? Yeah. And I say, well, what's really important here is that we get the job done, not how big the incision is. And so maybe if it's doable with minimally invasive, okay. But if it's not, then we don't want to do a job that's not enough because just to make it minimally invasive. I mean, that's just one example of, patients often come and they say, oh, I want this procedure. I want you to use this device because there's a lot of direct consumer marketing. They see a television advertisement or they see something like that, and they come and they tell you what to do. And so, you can try to explain to them, half the visit is trying to uneducate them about something that they didn't understand wasn't for them. But I think that if they feel that you look them in the eye, that you have their best interest at heart, that you're not ignoring them and you're trying to do the right thing for them, I think most people will listen. Most people, are, I mean, some people you can't reach, and it's better for them to go away anyway. But most people, I think, are pretty reasonable.
Thank you, Professor Mark. I hope our young surgeon is really understand what we are already talking about it. Yeah. So Didi, please.
Yeah. Thank you, Dr. Ifran. Thank you, Dr. Mark. As you say, it's right. Nowadays, a lot of people come to us and want to do PLDD, PLD, whatever the D is, everything is endoscopic. I don't know. Okay, there is another question from the floor, please. Dr. Widya Stuti.
Thank you for the opportunity. Good morning, Prof. Mark. First of all, thank you very much for your very inspiring lecture, very useful for us. I want to ask, in our practice, we found a lot of patients with specifically adult spinal deformity. A lot of them have cardiac problem, whether neglected cardiac problem or also cardiac problem that hasn't been resolved. So based on your countless and myriad experience, maybe please share with us your suggestion or your insight for us to be able to prepare better for this specific demographic of patient, Prof. Thank you very much.
Thank you, Dr. Desi.
Thank you.
Please, Prof. Mark, there is a lot of problem in cardiologists in patients with adult spinal deformity, either cervical or others. Whether we do solve the cardiologist or we solve the spine, maybe with heavy things. Please, Prof. Mark.
Again, thank you. That was a beautiful question. So this is what I tell that patient when they come. I say, one of the best things, it's great that you came. One of the best things that you did was that you have back pain, or that you have, because now we can start taking care of your heart. If you didn't have this back pain or this neck pain or whatever it is, you probably wouldn't go to the doctor. But now that you do, now we can see that there's a problem with your heart and we can get that fixed. And once that's fixed, then we can do the other, fix the spine or whatever it is. So I try to make it a positive experience for them. Then, is the problem that is the doctor the problem? Sometimes the cardiologist is the problem. Sometimes the patient is the problem because they don't listen or they don't, whatever. But I'm just saying that I try to make the visit to me, even though I'm refusing to touch them and operate on them, I'm trying to make it a positive experience, for them. And I invite them to come back, come back, in 2 months, let's see what's happening with your cardiac situation. Let's see how it's improved, blah, blah, blah. And I also, again, for the younger doctors, it's very, very helpful to have several contacts with the patient before you decide to do surgery, so that they start to know you and have a relationship with you. And it's, again, we're not just operating on an X-ray, and they need to know that.
Thank you, Prof. Mark. Is there any question from the audience? Okay, if there is no question, I would like to ask your opinion as previous question. How about if the patient is already paresis, tetraparesis with cervical problem, also have cardiac problem? How you solve it? Thank you.
Oh boy. So it depends. If the cardiac problem is really, it's like, which one is worse? If there's a way, if the person is really bad from a cardiac standpoint, we at Columbia are fortunate that, we can put people on pump, or we can get, we have pretty good cardiology and cardiac surgery if they really need it. But I would probably prioritize the paresis, because that's just not going to go well unless they say to you, if they say to you, if you touch this patient, they're going to die, then we can't. But unless they say that, I would say that I would try.
Thank you very much, Dr. Ifran. Do you have any comment?
No, I think we have to make patient understand. The cardiac can make the patient die, but neck and back pain cannot make patient die. So they have to choose. Yeah, if there is so risky, from the cardiac side, to do the surgery, I think we just say that to the patient. Cardiac can make you die immediately, but the neck and back problem, this cannot make you dying. That's why they have to choose. Yeah, if they want to try to the surgery, that means you have they're ready to get the worst complication after the surgery or during the surgery. Thank you.
Thank you, Dr. Ifran. So there is no question from the floor. Time is up. Thank you, Prof. Mark, Dr. Ifran. We are very happy your participation in National Health Days today in our hospital. Thank you very much. Again, Prof. Mark and Dr. Ifran. Give applause to them.
Thank you, Prof. Mark. Yeah. Good evening. Yeah. See you again.
I just want to again say thank you for the opportunity to do this. I love you guys, and I would also like to thank Dr. Cyril Lizdawati and Mokwago. I apologize for mispronouncing your names for allowing me to do this. And you're all welcome to Colombia anytime.
Thank you, Mark.
Thank you. By the way, a little bit speak from one of our director. He wants to invite you when you come next year. Please, Dr. Wahyu. He is also an orthopedic, but he is in the extent of the spine. He's a hand surgeon.
Hello, Professor Mark. Hello, Professor Mark. Can you hear me?
Yes, sir, I can.
Oh yeah, it's very nice, and then nice to meet you. And I'm very happy because you can join with us in this webinar. So I heard from Dr. Didik you will come to Jakarta maybe next year. So we are very happy to invite you to come to our hospital. Maybe we can discuss another case, and then you can give you sharing your competency or your knowledge and then skill in our hospital. Maybe we must arrange with the Dr. Ichal as a chief of department in this. Thank you very much.
Thank you, Dr. Wahyu.
You are too kind. All of you are too kind. Thank you so much. I would love to do that.
Thank you, Prof. Mar. Thank you. Again, thank you. Bye-bye.
Baik, terima kasih pada Dr. Didik dan Dr. Ifran dan juga Prof. Marks atas materi dan diskusi yang sangat menarik, dan mungkin saya yakin dapat memberikan manfaat kepada kita semua, bukan hanya spine surgeon tapi juga soon to be orthopedic surgeon, residen dan sebagainya. Saya ucapkan selamat datang. Oh ya, one more big applause to our seminar and also to Prof. Mark. Terima kasih. Saya ucapkan selamat datang juga kepada Direktur Medik dan Keperawatan RSUP Fatmawati, Dr. Wahyu Widodo, SPOT Konsultan, dan juga Ketua SMF Ortopedi dan Traumatologi Fatmawati, Dr. Faisal Mi'raj, SPOT Konsultan. Sesi berikutnya akan kita lanjutkan masih dengan topik spine, namun kali ini akan dibahas lebih dalam dari aspek rehabilitasi medik. Karena itu kami mengundang moderator Dr. Shinta Dewiana, spesialis kedokteran fisik dan rehabilitasi medik untuk ke depan panggung. Dipersilakan, Dok. Izinkan saya sekilas membacakan CV beliau. Beliau lulus sebagai konsultan kedokteran fisik dan rehabilitasi medik dari Universitas Indonesia pada tahun 2020, dan saat ini beliau bekerja di Rumah Sakit Siloam TB Simatupang, Rumah Sakit Fatmawati, dan juga aktif di Life Spinal Care Jakarta. Silakan, Dok.
Thank you, Dr. Erwin, for the introduction. So for the next session, we have the rehabilitation management of scoliosis. The speaker is Dr. Krista Adrian Tenges, spesialis kedokteran fisik dan rehabilitasi konsultan. Dr. Krista is a physiatrist in a musculoskeletal division in Rumah Sakit Umum Pusat Fatmawati and finished the school as a PMR specialist in Universitas Indonesia, Jakarta. Please, Dr. Krista, to come up to the floor. Okay, for the second session, we will bring the presentation in English. Okay, for the next session, we will bring the presentation in English, but in the discussion will be bring with Bahasa. So without further ado, please, Dr. Krista, for the presentation. Thank you.
Thank you, Dr. Sinta, for the introduction. Before I start my presentation, can I just get off of the stage? It feels a little awkward to stand over here. Thank you. Okay. Good morning, dear doctors and all the participants. Thank you for having me to share about the rehabilitation management of scoliosis. By the end of this session, our target is that all of these questions can be answered. Which conservative treatment should be provided and how? How and when should bracing be applied? And how and when should exercise be used? I believe that everyone here already know how to diagnose scoliosis. So I'm just gonna jump right into what are the basic objectives of a comprehensive conservative treatment. First of all is to stop the curve progression at puberty. And if it's possible, we try to reduce it. You know, current evidence shows that a really tailor-made conservative treatment did really help at stopping the progression of the curve. The second is to, The second is to prevent or treat respiratory dysfunction. It really depends on its location and its curve. The most prominent changes within the respiratory function, it's the curve that progress in the thoracic area. And then the third is to prevent or treat the spinal pain syndrome, which are the later on symptoms that may be developed by the patient. And of course, to improve aesthetic via postural correction. We know that quality of life is significantly affected by the aesthetic, the external appearance. Most of the scoliosis patients are girls, women. So how they look, how the physical appearance is important. That's why visual correction related to the external trunk deformity is really an issue in conservative treatment. Then coming to a wrong decision make us to face one of these two main mistakes in conservative treatment. First is overtreatment. Overtreatment means that there are too much burden for the patient with no improved efficacy. And then the second is undertreatment, where the treatment itself did not bring any improvement, nor little or no improvement at all. So how do we treat scoliosis? In conservative treatment, it really depends on the curve magnitude and patient age. When the patient is at the skeletal immature, or it means that the patient still have growth remaining, then the curve magnitude is very important. If the curve is less than 25, then we observe. We observe every 3 months, every 6 months, and so on. And if the curve is within 25 and 45 degrees, then brace is an option. When we give the right brace, the right forces at the right time, it will give benefit to the patient. And if the curve is more than 50 degrees, then surgery is an option. For skeletal mature, when there are no growth remaining, we observe. Unless the curve is more than 50 degrees, then surgery is an option. So how do brace work? Before I continue with brace, I just want to make clear that sometimes there are misperception about bracing and corset. There are two different type, like both of them are orthosis, spinal orthosis. But brace are a stiff jacket that provide constant force. Meanwhile, corset is a spinal orthosis. It's a soft orthosis. It only gives kinesthetic reminder. So it's different between brace and corset. Okay? And it said that brace work best when it worn all the time, from 16 to 23 hours a day. It have many different kind of brace. Almost everyone try to make their own brace. And bracing is stopped when the child is stop growing. This is some other consideration when we use brace. If the cup angle has reached at least 25 degrees and still have significant growth level, and when the cup angle is less than 25 degrees but has rapidly progressed at least 5 degrees in 4 to 6 month follow-up. And then what are our consideration when we try to give patient brace? First is we have to always keep in mind that scoliosis not only affected the musculoskeletal system, but it also affected the cardiovascular and respiratory system as well. And some studies shows that brace can reduce all the FVC % and FEV1 % in thoracic area. So before giving brace, we do the evaluation of the physical capacity. It is important. And also we have to see about the severity index, the two-dimensional cup angle. How about the vertebral axial rotation at the apical level? How about the intervertebral axial rotation at the upper and lower region? We have pay attention also on the torsion and hypokyphosis index. Okay, then what to evaluate? Some perceptions say that the in-brace cup angle correction must be 50% to be said it is successful bracing. But this is true, it is often true, but not all patients can be in 50% in brace cup angle correction. For this example, this is one of the patients that have 48 to 50 degree of the scoliosis. And at this time, I decided to give only like 25% correction, in brace correction. Why? Because this patient already have symptoms about respiratory. They already have decrease in maximal capacity. So if we gave for more than 40% in brace cup angle correction, the brace will be painful and it's not easy to wear. So sometimes some patients are best served with low correction, but will also give benefit after 6 or 1 month, 1 year later. So there's not always said that it has to be 50% correction, then the brace is successful, but 25 to 50 is still acceptable. This is just some example of the braces. There are Boston brace, Charleston, and Providence brace that it said that it needs to be worn like 18 hours per day. And there are some of the example of the nighttime braces also. And well, this is one of my favorite brace. It's the Rigoshano type. It's a dynamic brace when it gives expansion room to accommodate the migration growth and breathing movement as well. It is tailor-made and it makes depend on the skeletal maturity, about the curve, also flexibility of the trunk. Okay, this is some example from 2 scoliosis patients where they have similarity in curve, but they have been given different braces. So it depends on the shoulder symmetry as well, and also if there are any breathing dysfunction, so we gave also different brace as well. Okay, the big problem is when we already have the brace, we already manufacturing it, but the patient don't want to wear a brace. That is the big problem, and it happen almost all the time. It is important to learn why the patient don't want to wear braces. When the statement are out from the patient, we already know, and we can say and find the solution together. The steps that we can take is acknowledge that the inconvenience is temporary. Most of the patient don't feel convenience to wear brace for the first month, but after that they will get used to it. And it's important to us to explain why bracing works. It's also said that to get family and friends to over support will help the patient to use the brace. And if all the things we already done and the patient still don't want to use brace, we can see if a nighttime brace is an option. Although it said that the more the wear of the brace is more good, then we can see if a nighttime brace is an option because it is better than none. And I'm gonna talk a brief about exercise. Well, actually, scoliosis specific exercise typically is used to prevent deformity progression. It's improve quality of life, posture, muscle endurance, and also prevent consequence during adulthood. This is originally made as an add-on to bracing. What we call a physiotherapeutic scoliosis specific exercise, it should consist of autocorrection in 3 dimensions. So it is a specific pattern for the patient. And then we do training in activity daily living. And also it should consist of stabilizing the corrected posture. And there's a lot of education as well. So we can see here there are some autocorrection in 3D where we put some some pillow over the pelvic and everything. So specific, the PSSE have been associated with different brace design. There are some exercise that called side shift exercise. It is made for a net on Milwaukee braces and the other exercise as well. It's associated with the different brace design. It's also said that aerobic exercise is indicated in the preoperative period. Okay, this is some example of the Schroth method when the exercise is about to make the alignment of this 4 block of body become more balanced between the left and the right one. And this is some example about the IDL in exercise in activity daily living. So we try to put the correct posture in every day of the activity of the patient. Okay. In conclusion, the level 2 evidence support that the use of exercise, the specific scoliosis exercise in conjunction with the brace is useful if the curve is less than 45. And there are no scoliosis without the risk of secondary morbidity, and aerobic exercise is indicated in the preoperative period. And then we come into the respiratory function and exercise. It said that scoliosis that are more than 60 degrees, they will impact the respiratory system, and there are some impairment. First and the most seeing is the abnormal ventilation pattern, where most of it are mainly restrictive. And then the impaired function of respiratory muscle, the asymmetric motion of the chest wall, and also the abnormal pattern of ventilation during exercise. Some studies show that shortness of breath was only associated with curve more than 80 degrees. And its importance of performing general aerobic activity and respiratory training to improve exercise capacity and respiratory muscle function as well. This is some example about the breathing exercise that we gave. We can give inspiratory muscle training and also rotational angular breathing. This is the one method that are combined with the Schroth method as well. Okay. As a reminder, that conservative treatment, it's really depend on how actively the patient and caregiver are involved. We can give so much program for the patient, but if they don't actively involve, then the conservative treatment will be failed. And these are the crucial elements of conservative treatment. A lot of education, psychotherapy, systematic monitoring of outcome, assessment of patient compliance, and verification and modification of the method. And of course, I'm sorry about the slide, to gain and to have the best outcome of the conservative treatment, it will need to lead by the experienced rehabilitation team, are the physician, the orthotist, the physiotherapist, and sometimes we also need the psychologist as well. Well, that will be all for attention.
Thank you, Dr. Krista. Terima kasih. Izinkan saya untuk membawakan diskusi dalam bahasa Indonesia. Apakah sudah ada pertanyaan dari peserta? Ya, Dr. Erwin.
Selamat pagi dok, terima kasih atas materinya yang saya rasa sangat penting buat kita semua, terutama dalam aspek rehabilitasi medik ya, konservatif. Mungkin saya ada dua pertanyaan. Yang pertama terkait skoliosis dok ya. Kalau di rehab medik itu, apakah dokter-dokter mengukur fleksibilitas dari curve? Karena tentu itu penting ya, bukan hanya untuk koreksi, kita sebagai surgeon, kebetulan saya orthopedic surgeon, saya melakukan koreksi, tapi apakah dalam melakukan pengukuran brace, dokter melakukan manuver tertentu untuk mengukur fleksibilitas dari curve pasien? Itu nomor satu. Yang kedua, mungkin di sini banyak peserta kita dari residen ya, mungkin yang penting itu kira-kira apa saja kriteria fail. Kapan dokter menentukan ini fail nih, kita brace ini fail gitu, atau mungkin setelah sekian lama, sekian bulan dokter brace, pasang brace, oke ini fail. Nah kira-kira dari segi sudut kah atau mungkin dari segi compliance itu ada kriteria nggak yang kita bisa sebagai mungkin general atau mungkin soon to be ada yang tertarik spine atau sebagainya untuk bisa lihat itu sehingga kedepannya bisa tahu kapan melakukan surgery. Terima kasih.
Terima kasih Dr. Erwin. Berarti dua pertanyaan. Yang pertama mengenai apakah ada manuver tertentu yang dilakukan pada saat pengukuran brace terhadap curve dari pasien skoliosis. Dan yang kedua, kapan kita katakan bahwa treatment konservatif kita fail? Silakan Dr. Krista.
Terima kasih pertanyaannya Dr. Erwin. Tadi bertanya soal fleksibilitas trunk ya. Ya, ini sangat penting untuk kita perhatikan juga karena seandainya fleksibilitas trunk itu masih baik, kita punya chance untuk bisa sedikit merubah curve-nya atau mengurangi begitu. Jadi memang saat kita buat brace, tujuan utamanya adalah untuk menahan supaya tidak terjadi progresivitas daripada kurva itu. Tetapi dengan fleksibilitas trunk yang masih baik, itu yang akan bisa membuat latihan juga jadi lebih mudah dan kita mengharapkan adanya perubahan dari sudut walaupun tidak terlalu besar seperti itu. Dan sebenarnya untuk fleksibilitas trunk itu lebih kita pakai saat latihan. Untuk kita bisa lihat dalam artian begini, fleksibilitas trunk bisa disebabkan satu, memang dia ligamen laxity yang lebih, atau yang kedua muscle weakness. Nah di situ kalau memang terdapat muscle weakness kita akan lebih concern ke kita kuatkan ototnya, dan kalau dia lebih ligamen laxity latihannya pun akan lebih berbeda. Ada beberapa hal yang tidak boleh kita kerjakan. Sedangkan untuk proses bracing itu sendiri, fleksibilitas trunk biasanya kita pakai kalau kita mau bikin yang tadi Shano Rigo brace. Jadi dia memang ada satu celah yang akan kita kasih untuk force balik dari pola nafas sih sebenarnya. Jadi memang untuk fleksibilitas trunk ini juga penting untuk kita evaluasi saat pertama kali kita terima pasien.
Oh iya. Maaf dok, menyambung dok, maksudnya berarti ketika rehab membuat brace itu patokannya itu curve di standing atau curve saat bending, gitu dok?
Nah kalau bikin brace ada dua ya. Kalau kita sih pakainya adalah yang saat standing, curve yang saat standing yang kita pakai. Ada yang satu lagi namanya night time brace. Kalau untuk pengalaman saya memang kurang menggunakan itu karena itu lebih nyeri menurut pasien gitu. Itu yang digunakan adalah saat bending gitu. Jadi kita lebih sering menggunakan adalah saat standing, baru kita coba untuk dorong curve-nya. Jadi penempatan paddingnya akan sesuai dengan apikal daripada si curve itu. Terus pertanyaan yang kedua,
Kapan kita katakan bahwa
itu fail?
konservatif gagal?
Biasanya antara itu akan berhasil atau tidak sudah mulai bisa dilihat dari pertama kali kita terima pasien. Bagaimana penerimaan pasien itu sendiri, support daripada orang itu sendiri gitu. Biasanya kita katakan failed kalau dalam setiap kali kita follow up, which is setiap 6 terjadi peningkatan. Terjadi peningkatan daripada curve, biasanya kita lihat apakah ada yang salah dari chartnya, atau ada yang salah dari padding, ataupun ternyata memang ini merupakan suatu progresif skoliosis yang tidak dapat ditahan oleh brace begitu. Biasanya kita akan evaluasi sampai 2 kali 6 bulan. Jikalau dia tetap nambah terus dan penambahannya lebih dari 5 derajat, itu kita katakan failed dan kita rujuk ke sejawat ortopedi, seperti itu.
Sudah puas, Dokter Erwin? Mungkin ada pertanyaan lain dari peserta? Oke, bisa sebutkan nama.
Terima kasih Dokter Krista, saya Dokter Daniel. Yang mau saya tanyakan, setelah operasi koreksi skoliosis, apakah penggunaan brace itu masih tetap diperlukan? Terima kasih dok. Jika diperlukan, kenapa ya dok?
Terima kasih pertanyaannya. Setelah koreksi skoliosis, sebenarnya kita tidak membutuhkan brace lagi karena justru stabilisasinya sudah dilakukan internal. Tapi mungkin ada pilihan kita berikan korset atau soft orthosis. Tujuannya adalah untuk kinesthetic reminder. Jadi kan pasien dalam posisi skoliosis sudah dikoreksi internal, sudah pasang posterior stabilisasi, itu udah lurus, udah stabil. Tapi si pasien perlu edukasi bagaimana dia mempertahankan posisi tegaknya itu. Jadi biasanya kita hanya akan butuh soft orthosis saja seperti korset, kecuali memang dari sejawat ortopedi bilang bahwa ini ada yang nggak stabil, tolong distabilisasi dari luar, baru kita bisa bikinkan body jacket. Biasanya untuk koreksi yang sangat besar seperti itu, tapi itu jarang kita kerjakan. Jadi pilihannya adalah soft orthosis yang kita berikan.
Oke, selanjutnya ada pertanyaan dari Zoom. Apakah perbedaan antara soft dynamic brace dengan Rigo Sheno hiperkorektif dan Boston? Dan kapankah kita memberikan brace tersebut dan indikasi apa yang diberikan yang terbaik yang paling baik dari setiap brace kepada pasien? Mungkin indikasi setiap pasien terhadap soft dynamic brace dengan Rigo Sheno dan juga Boston, Dr. Krista.
Baik, terima kasih atas pertanyaannya. Apa bisa ditampilin lagi? Oke, perbedaan antara soft dynamic brace. Ya, tadi saya tidak mention dalam presentasi saya soal soft dynamic brace. Jadi ada memang tipe brace yang soft dynamic. Jadi dia spine core ya Dokter Sinta namanya. Jadi itu dia pakai kayak semacam tali dan ada beberapa tempat yang dia kerjakan. Memang saya saya tidak punya pengalaman dengan menggunakan soft dynamic brace ini karena memang sesuai dengan guideline SOSOR juga dikatakan bahwa tidak terlalu banyak mungkin belum terlalu banyak penelitian yang mengatakan bahwa ini oke dibandingkan dengan rigid brace gitu karena ya kalau untuk soft dynamic brace saya rasa saya tidak bisa banyak berkomentar karena saya tidak punya pengalaman untuk itu. Kemudian
Antara Rigo dan Boston.
untuk Rigo dan Boston sebenarnya tergantung dari kurva itu sendiri gitu. Jadi pada dasarnya Rigo dan Boston ini juga bekerja 3 dimension correction ya gitu. Cuma memang kalau yang Rigo Shano ini dia lebih banyak kasih ruang untuk adanya chest expansion gitu. Jadi dua-duanya ini akan bermanfaat dan memang kita harus lihat dulu bentuk kurvanya juga seperti apa, apakah rotationnya yang lebih banyak dan yang lainnya. Kalau untuk rotation yang lebih besar, mungkin saya akan lebih prefer untuk memberikan yang Rigo Shano brace.
Kemudian yang nomor 2 mengenai latihan di rumah yang sangat simpel yang dapat diberikan pada anak-anak atau pada remaja dengan skoliosis.
Kalau latihan yang paling mudah adalah berenang. Setiap pasien skoliosis saya minta untuk harus wajib kudu bisa berenang. Bukan sekedar main-main air, tapi benar-benar ada coachnya untuk latih. Kenapa berenang? Karena masalahnya adalah di core muscle weakness. Dan paling gampang untuk menguatkannya itu adalah dengan berenang. Itu berenang gaya bebas atau gaya katak ya. Itu dua-duanya akan bantu untuk extensor trunk jadi lebih bagus. Dan latihan di rumah bisa di-combine juga dengan beberapa core muscle exercise. Itu ada banyak yang bisa dikerjakan, misalnya mulai dari bridging, mulai dari plank yang dimodifikasi yang akan lebih nyaman untuk anak-anak seperti itu.
Menyambung nih dok, pas tentang exercise, ada yang dikatakan bahwa exercise in bracing. Exercise in bracing kadang-kadang banyak yang mengatakan bahwa jika latihan di rumah tuh harus menggunakan brace karena pemakaian brace-nya tadi 16 sampai dengan 23 jam tadi. Jadi kalau di rumah itu apakah exercise in bracing itu dikerjakan juga kah?
Well, sebenarnya exercise in bracing itu juga bisa tetap dikerjakan. Cuma memang gerakannya nggak begitu banyak ya. Kita lebih fokus pada isometrik, pada kontrol posturnya seperti itu. Jadi kalau saya biasanya akan edukasi ya pasien kalau mau latihan brace-nya dibuka dulu. Gitu. Jadi kita punya range antara 16 sampai 23 jam, bukan berarti dia harus pakai terus juga dalam latihan gitu karena saat awal kalau back muscle itu belum direedukasi, mereka nggak akan ngerti untuk gerakan yang benarnya gitu. Jadi prefer untuk out brace exercise dibandingkan dengan in brace exercise.
Oke, terima kasih Dr. Krista. Mungkin masih ada pertanyaan lain? Oke, silakan dok.
Terima kasih Dr. Krista atas penjelasannya. Saya Amanda ingin bertanya dok, tadi dokter menyebutkan bahwa untuk penggunaan brace untuk skoliosis ini kan berkisar antara 16 sampai 23 jam dok. Nah kira-kira faktor apa yang kita harus perhatikan pada pasien ini, dia butuh 23 jam, pada pasien ini cukup hanya 20 jam saja seperti itu. Kemudian yang kedua mengenai exercise dok, tadi kan salah satu masalah pada pasien dengan skoliosis terutama yang curve-nya itu di level thoracic adalah gangguan kardiorespiratori dok. Tapi kan tadi dokter sebutkan exercise yang paling baik itu adalah aerobik. Apakah ada concern tertentu yang harus kita perhatikan sebelum mempreskripsikan latihan kepada pasien dengan skoliosis? Terima kasih dok.
Terima kasih Dokter Amanda pertanyaannya.
Dari faktor yang menentukan bahwa kita menentukan 16 sampai 23 jam.
23 jam. Sebenarnya itu juga kita tentukan menurut dengan skeletal maturity-nya. Kalau misalnya pasien masih dalam fase kita katakan awal-awal puber ya, yang bisa kita lihat lewat X-ray masih research 0, research 1, di mana perkembangan itu akan bisa jadi lebih cepat dan curve progression itu juga jadi lebih besar. Biasanya kita sarankan untuk dipakai memang 23 jam per hari. Gitu. Jadi non-stop dibuka saat mandi aja, saat lagi sholat atau olahraga, habis itu langsung pakai lagi. Tapi seiring pertumbuhan usia dan kalau kita udah lihat berapa kali kita follow up dan dia oke dan tidak ada tanda-tanda bahwa ini merupakan progresif skoliosis, kita bisa kurangi pemakaiannya. Biasanya saya akan mulai kalau dia sudah lewat setengah daripada immature skeletal itu. Jadi udah mulai ke research 3 sampai 4, kita bisa kurangi jadi 16 gitu. Seperti itu.
Kemudian pada pasien dengan curve-nya lebih dari 60 tadi yang
aerobic exercise ya. Kalau untuk aerobic exercise, prinsipnya sama dengan semua aerobic exercise yang kita berikan. Kita start slow, low, and moderate. Bertahap, pastinya ada pemeriksaan-pemeriksaan yang kita lakukan dulu. Kita lihat fungsional kapasitinya seperti apa, dan kita akan naikkan bertahap. Yang penting dalam aerobic exercise adalah bukan seberapa lama dia lakukan atau seberapa cepat dia lakukan, tetapi apakah gerakan itu benar, seperti itu. Dan biasanya kita combine-kan dengan breathing exercise as well. Seperti itu.
Mungkin mau menambahkan mengenai breathing exercise sendiri, karena salah satunya itu memang kita biasanya pada fisiatris mengukur yang namanya chest expansion. Chest expansion itu adalah salah satu cara kita melihat apakah flexibility dinding dadanya masih baik atau tidak. Jadi itu bisa dijadikan patokan juga, apakah dengan adanya skoliosis ini betul-betul ini ya dok terganggu atau tidak. Bisa dari situ sih dok. Mungkin ada yang lain lagi? Ya dokter silakan.
Terima kasih dokter atas kesempatannya. Saya Kevin. Saya ingin bertanya untuk scoliosis specific exercise itu izin dok, ada durasi dan regimen khusus dok, dan dari pengalaman dokter bagaimana compliance dari pasien dok untuk exercise. Untuk yang kedua penggunaan korset dok untuk pasien-pasien dengan kurvatur yang kecil dok di bawah 20 derajat, apakah ada benefit dari penggunaan korset? Terima kasih dok.
Terima kasih dok atas pertanyaannya. Kalau untuk durasi daripada specific scoliosis exercise itu basically sama kayak exercise yang lain. Bisa kita kerjakan 2-3 kali seminggu, karena tujuan pertama adalah pasien paham dulu nih. Kalau tadi ada 4 block mulai dari latihan bagian shoulder, thoracal, lumbal, dan pelvic. Biasanya berapa lama dilatih itu tergantung dari pengertian pasien itu dulu. Gitu, dia bisa aktivasikan yang mana dulu nih, gitu. Jadi memang bertahap, dan kalau sesuai dengan pengalaman saya mungkin akan butuh waktu lebih dari 1 bulan biasanya untuk si anak ini dapat mengerti. Dan kalau untuk anak kita agak lebih start slow, karena begitu banyak informasi yang masuk dia akan lupa. Minimal 1 aja yang bisa dia pahami, dan memang targetnya adalah untuk bikin balance antara otot yang kiri dan yang kanan, seperti itu. Nah, kalau yang untuk pertanyaan kedua tentang korset
compliance pasien
kalau di bawah daripada 20 derajat apakah ada manfaatnya ya? Tidak ada. Gitu, tidak ada, karena kalau di korset itu kembali lagi tujuannya hanya untuk kinesthetic reminder. Jadi cuma ngingetin buat tegak aja gitu. Sedangkan pakai korset itu ada untungnya ada ruginya. Ruginya adalah saat pasien ini pakai korset, dia akan lupa harusnya aktivasi otot seperti apa, karena itu dikerjakan oleh korsetnya. Jadi biasa kita nggak kasih korset, kita nggak kasih apa-apa kalau masih di bawah 20 derajat, tapi kita latih untuk core muscle-nya aja, dan habis itu di follow up kembali, seperti itu.
Satu lagi dok, compliance pada latihan scoliosis specific exercise.
Compliance-nya kalau pada setting rumah sakit sebenarnya agak rendah ya. Rendah. Satu adalah bahwa rata-rata anak sekolah. Mau pagi nanti bolos sekolah, mau sore udah kecapean, dan beberapa rumah sakit memang kita pelayanan cuma sampai siang begitu. Jadi jadwal pulang sekolah sudah tidak bisa. Jadi compliance-nya agak lebih sulit ya kalau untuk anak-anak, apalagi kalau dia usianya lebih muda lagi. Makanya saya selalu modalin dengan anak ini harus bisa berenang, gitu. Karena itu adalah fun activity. Tapi kalau latihan pakai disuruh kencengin ini, suruh tarik ini, it is boring, gitu. Jadi lebih baik pasien berenang, karena pada dasarnya exercise ini adalah tambahan, gitu. Tapi mainnya adalah kita kasih brace, exercise ini sebagai tambahannya, seperti itu.
Panjat tebing juga bisa. Kadang-kadang kita menggunakan itu biar lebih fun pada anak di atas 8 tahun ya dok ya. Ya dokter Krista selalu minta untuk panjat tebing. Oke. Ada lagi mungkin pertanyaan dari audiens? Ya, silakan dokter.
Ya, izin saya Filberto. Izin bertanya dok mengenai berenang. Itu apakah ada gaya khusus untuk anak-anak berenang? Dan kira-kira untuk durasi yang bagus berapa lama ya dok? Apakah 1 jam, setengah jam atau bagaimana dok? Terima kasih dok.
Terima kasih dok atas pertanyaannya. Berenang seperti apa? Berenang yang akan menguatkan ekstensor trunk dan bikin balance antara kiri dan kanannya. Jadi kita sarankan untuk gaya bebas dan gaya katak. Seperti itu. Jadi pokoknya dibikin balance antara kiri dan kanan dan kita harapkan core muscle-nya benar-benar jadi nih. Gitu. Untuk durasinya tidak ada durasi yang spesifik. Kalau kita berdasarkan pada basicnya aerobik itu, kita mulai dari 15 menit, bertahap sampai 30 menit, maksimal sampai 1 jam. Seperti itu.
Ada pertanyaan lagi dari Zoom. 3 jenis, oke. Apakah ada perbedaan dalam memberikan in-brace exercise pada ketiga tipe brace, yaitu Milwaukee, Boston, sama Rigoshenu? Dan hidroterapi dalam tata laksana skoliosis, baik dari literatur maupun pengalaman.
Oke. Kalau pemberian in-brace exercise, ada bedanya sebenarnya untuk Milwaukee. Itu mereka menggunakan side shifting exercise gitu, karena Milwaukee akan nahan sampai ke area cervical. Jadi latihannya akan sedikit lebih berbeda. Tetapi kalau untuk Boston dan Rigoshenu itu kurang lebih in-brace exercise-nya sama saja. Lalu untuk efektifan hidroterapi dalam tata laksana skoliosis, ini latihan hidroterapi kita lebih banyak gunakan untuk pasien-pasien skoliosis yang sudah pada usia dewasa ataupun lanjut usia. Misalnya skoliosis de novo. Karena hidroterapi ini sendiri akan bantu supaya pasien ibaratnya tidak terlalu sulit untuk latihan di darat gitu. Jadi kalau dari literatur memang ini cukup efektif untuk menguatkan core muscle dan memang kita biasanya berikan untuk pasien-pasien dewasa ataupun lanjut.
Oke, baik dokter. Tinggal 5 menit lagi waktu yang ada buat kami. Apakah masih ada pertanyaan dari peserta seminar? Ya, silakan dokter.
Izin bertanya dokter, selamat pagi. Tadi dijelaskan bahwa ada beberapa kasus yang tidak dilakukan full correction ya dok, aja misalnya hanya 25% saja. Nah itu apakah ada specific consideration atau parameter tertentu yang dipertimbangkan, misal pada pasien ini sekian persen koreksinya, pada pasien ini sekian persen gitu. Terima kasih dokter.
Maaf dokter, bisa diulang agak besar suaranya?
Oh ya. Mohon maaf dokter, tadi dijelaskan di presentasi bahwa ada beberapa kasus yang tidak ditata laksana full correction, misalnya 25%. Nah itu apakah ada specific consideration, parameter tertentu yang dipertimbangkan, misal pada pasien ini dilakukan koreksi seberapa besar dan seberapa persen gitu dokter? Terima kasih.
Parameter yang dibutuhkan untuk menentukan treatment pada mereka yang di bawah 25 derajat.
Bukan, tadi kan ada beberapa yang ditata laksana, misal pasien ini dikoreksi 25% saja atau 5% gitu. Ya. Parameter yang dipertimbangkan apa gitu.
Oke,
terima kasih.
Baik dokter, terima kasih dok.
Terima kasih dok atas pertanyaannya. Ya, yang perlu diketahui bahwa seberapa besar kita koreksi itu juga bergantung pada fleksibilitas dari trunk. Kalau fleksibilitasnya sudah minimal, kita paksa untuk lebih dari 50%, itu akan sakit. Itu yang pertama. Jadi kita cek juga fleksibilitasnya seperti apa. Yang kedua adalah beberapa pasien walaupun memang secara literatur dikatakan 60 derajat baru akan ada gangguan pernapasan, tapi beberapa pasien dengan sudut yang nggak gitu besar, tapi dia tepat berada di mungkin di area T6, sekitar T6 sampai T10 itu sudah mulai memberikan dampak kepada fungsi respiratorinya. Nah kalau kita kasih brace, sedangkan belum pakai brace dia udah agak sesak atau capek, kita tambahkan dengan brace, dia akan lebih capek lagi, akhirnya brace itu tidak akan dipakai. Nah itu salah satu dari beberapa pertimbangan kita, apakah emang perlu full atau enggak. Biasanya kita akan coba dalam proses pembuatan itu, kan padding itu bisa kita tambah tebal dan yang lainnya untuk menentukan seberapa besar akan kita koreksi. Kita coba dulu, dia masih nyaman, terus kita cek pakai Pika Flow dan dia masih oke, kita bisa tambah. Kalau udah enggak berarti cukup sampai situ aja. Seperti itu sih kurang lebih.
Baik dokter, terima kasih atas pertanyaannya. Karena waktu kita sudah habis, jadi izinkan saya untuk menutup diskusi pada sesi kedua kali ini. Kesimpulan mengenai rehabilitation management of scoliosis, di mana scoliosis ini sendiri memiliki pengaruh terhadap tubuh kita, tubuh pasien selain divisi muskuloskeletal. Kemudian peranan konservatif manajemen merupakan peranan yang memiliki tempatnya sendiri dalam penanganan skoliosis, dan pemberian brace merupakan tailor-made atau tergantung dari pasien, di mana dalam menentukannya dibutuhkan pemeriksaan komprehensif dari dokter rehabilitasi medik dan tim. Oke, sekian dan terima kasih dari sesi 2. Kita kembalikan ke panitia. Terima kasih.
Ya, saya ucapkan terima kasih kepada Dr. Krista dan Dr. Shinta atas topiknya yang saya rasa sangat bermanfaat ya, terutama kalau diperhatikan tuh pasien-pasien skoliosis itu biasanya takut operasi dok. Ya, jadi memang tidak semua solusinya operasi. Jadi kita suatu kolaborasi dengan tim, pada beberapa indikasi kita bisa melakukan fisioterapi dan konservatif. Dan hadirin sekalian, berikutnya kita akan masuk ke sesi kedua. Ya, tadi kita sudah bicara mengenai spine, dan topik yang sesi 2 ini adalah hip. Kita sudah kedatangan 3 orang pembicara, yaitu Prof. John O'Donnell dari Melbourne, Australia, Dr. Jamot Silitonga, SPOT Konsultan, dan Dr. Yoshi Pratamajaya, SPOT Konsultan dari Divisi HIP RSUP Fatmawati, Jakarta. Dan untuk memulai sesi ini kami mengundang Dr. Yoshi Pratamajaya ke depan panggung yang sekaligus akan menjadi moderator sesi 2 ini. Izinkan sedikit membaca CV beliau. Beliau merupakan staf di Divisi HIP RSUP Fatmawati, Jakarta. Beliau lulus tepat mengambil fellow di Korea, dan juga saat ini aktif dan concern mengenai hip preservation atau hip artroskopi. Kepada Dr. Yoshi, kami persilakan.
Oke, terima kasih Dr. Erwin. Oke, tadi sudah perkenalkan, nama saya Dr. Yoshi Pratama dari Rumah Sakit Umum Fatmawati. Dan pada kesempatan kali ini kita akan memulai sesi ketiga mengenai sesi hip. Dan ada 3 pembicara yang mulai dari Dr. Jamot mengenai Enhanced Recovery After Surgery for Total Hip. Dan dia akan dijembatani mengenai hip preservation concept. Dan finally, our last speaker from Melbourne, Australia, Professor John O'Donnell, about the hip scope, the evolution, current practice, and future development. Oke, kita masuk ke pembicara pertama kita, yakni Dr. Jamot. Namun karena ada masalah dengan beliau, jadi beliau mengatakan maaf tidak dapat hadir. Jadi kita akan memberikan presentasi dengan melalui taping. Oke, jadi berikut CV untuk Dr. Jamot. Bisa ditampilkan. Oke, Dr. Jamot merupakan staf HIP di Rumah Sakit Umum Fatmawati. Beliau adalah lulusan FKUI tahun angkatan 94 dan merupakan lulusan ortopedi dari Fakultas Kedokteran Universitas Indonesia, dan saat ini bekerja di Rumah Sakit Umum Fatmawati sebagai our hip surgeon, and also juga bekerja di Eka Hospital BSD dan Rumah Sakit Pondok Indah. Oke, untuk slide-nya bisa langsung ditampilkan Dr. Jamot.
Selamat pagi, salam sejahtera bagi kita semua. Kami pertama mengucap terima kasih kepada panitia yang memberikan kami kesempatan untuk memberikan materi ini. Setelah mendengarkan paparan mengenai tulang belakang atau spine, kali ini kami akan mencoba memaparkan beberapa permasalahan di bidang panggul atau hip. Yang pertama ini saya akan menyampaikan mengenai ERAS atau Enhanced Recovery After Surgery, terkhusus pada kasus operasi total hip arthroplasty. ERAS ini merupakan multidisiplin dan multimodal care, di mana protokol ini ditujukan untuk meningkatkan outcome atau hasil dari operasi dan juga pemulihan daripada pasien itu sendiri. Di ortopedi sayangnya eras ini sedikit sekali laporannya, terutama untuk dalam negeri. Kalau untuk yang luar negeri sudah cukup banyak studinya. Tapi untuk kita di dalam negeri itu studi dan juga aplikasi dari protokol ini masih sangat sedikit dan jarang yang menggunakan. Dan sepengetahuan kami, kami merupakan yang pertama melakukan studi penggunaan protokol eras ini untuk operasi total hip. Sedikit mengenai sejarahnya, eras ini pertama kali dimulai oleh seorang dokter digestif atau bedah saluran cerna Denmark bernama Henrik Kehler sekitar tahun 1990-an. Beliau memulai untuk operasi-operasi saluran cerna. Kemudian Serok pada 1990-an juga memberikan laporan dan mencoba menerapkan penggunaan eras ini pada operasi-operasi total joint arthroplasty dan didapatkan adanya penurunan mortality atau angka kematian dari 0,44% menjadi 0,07. Kemudian laporan dari Malvia dan kawan-kawan yang melaporkan ada 1.500 kasus dengan eras dibandingkan dengan 3.000 yang tanpa menggunakan protokol eras. Didapatkan adanya penurunan lama rawat atau length of stay ya dari 6 hari menjadi 3 hari, dan juga adanya penurunan angka kebutuhan transfusi pasca operasi dan kematian dalam 90 hari. Jadi sekarang ini kalau kita lihat trennya bahwa penggunaan eras ini masih didominasi oleh obstetri dan ginekologi dan juga bedah saluran cerna atau digestif. Sementara di ortopedi sendiri masih belum begitu populer, dan terutama dalam negeri kita di Indonesia masih kurang diaplikasikan dalam operasi-operasi ortopedi. Padahal menurut pengalaman yang sudah kami mulai kerjakan dari mulai 2021 kemarin, sebenarnya protokol ini simple dan nanti kita lihat hasil studi kami bahwa hasilnya signifikan ya untuk dalam angka recovery dan juga outcome pasien itu. Jadi ini suatu hal yang menjanjikan untuk khususnya untuk ortopedi case ya. Ada studi berupa meta-analisis dan systematic review dari China, di mana dari 25 paper yang mereka komparasi atau kompilasi ada hampir 17.000 ya operasi total joint arthroplasty. Di sini ada total hip dan juga total knee. Mereka membandingkan antara yang menggunakan eras protokol dan tanpa eras protokol. Dari hasil systematic review ini didapatkan adanya penurunan signifikan dari angka kematian, angka kebutuhan transfusi, komplikasi dan juga lama rawat atau length of stay-nya. Jadi seperti kita tahu studi yang tertinggi adalah meta-analisis, di mana hasilnya juga sama ya untuk signifikansinya terhadap recovery dan juga length of stay-nya sangat signifikan. Nah, bagaimana eras untuk ortopedi? Kami memulainya itu karena kami merupakan bidang hip di Fatmawati, kami memulai untuk operasi-operasi total hip. Nah, eras di ortopedi itu dibagi 3 tahapan yang disebut perioperatif, yang dibagi menjadi pre, intra, dan post operatif. Jadi pada perioperatif ini nanti dilakukan adanya pemberian edukasi kepada pasien dari surgeon, karena kita ketemu pertama di poliklinik, apa itu ERAS, tujuannya apa, kita terangkan. Kemudian pasien juga akan ketemu dengan ahli gizi untuk menjelaskan pemberian nutrisi dan juga tujuan dari pemberian karbohidrat loading, bagaimana nanti mengenai puasanya gitu. Kemudian juga akan dilakukan juga pemberian preemptif analgesia ya, oral. Biasanya nanti kita berikan selama 1 minggu sebelum operasi. Kemudian di intra atau durante operasi biasanya dilakukan anestesi regional oleh dokter anestesi. Kadang dibutuhkan sedasi bila misalnya pasien dengan kecemasan yang tinggi. Dan goal yang diharapkan intraoperatif adalah tercapainya normotermi dan normovolemi. Kemudian mempertahankan sirkulasi dan juga pemberian antibiotik profilaksis. Untuk postoperatif sendiri yaitu tetap nanti akan continue memberikan multimodal analgesia dengan berusaha menghindari penggunaan opioid. Kemudian profilaksis untuk postoperatif muntah dan mual, nausea and vomit, dan juga dari rehab adalah dilakukannya early mobilisasi, dan dari gizi itu adalah pemberian oral intake yang early. Sebagai surgeon, apa yang kami lakukan yaitu pertama tadi preoperatif di poliklinik, pertama kali ketemu dengan pasien kami memberikan edukasi tentang operasinya sendiri dan juga tentang ERAS ini sendiri. Nanti jadi kemudian pemberian antibiotik profilaksis dan juga tadi pemberian oral analgesia yang biasa kita berikan 7 hari berturut-turut sebelum operasi. Kemudian pada saat operasi peran kita sebagai surgeon yaitu meminimalkan stress respon karena surgery kita, dan postoperatif adalah kita berkolaborasi dengan fisioterapi atau rehab medik untuk mencapai mobilisasi postoperatif yang dini dan juga mengevaluasi adanya komplikasi termopropilaksis dan juga bagaimana treatmentnya nanti. Untuk preoperatif kita berikan edukasi dan konseling yang tujuannya menurunkan kecemasan pasien, karena kan operasi total hip atau ganti sendi panggul itu sesuatu yang membuat pasien cemas. Mungkin bagi surgeonnya sih karena udah kerjaan harian mungkin dianggap seperti biasa, tapi untuk pasien kita bisa merasakan empati bahwa itu suatu operasi yang besar dan mengkhawatirkan. Jadi kita memberikan edukasi, kemudian juga sekaligus kita jelaskan mengenai protokol daripada ERAS itu sendiri, sehingga kecemasannya akan berkurang dan akan muncul kepercayaan diri, confidence ya dari pasien, sehingga itu ujung-ujungnya nanti akan meningkatkan hasil daripada operasi dan juga recovery-nya lebih dini. Mengenai antimikrobial profilaksis atau antibiotik profilaksis, ini memang guideline-nya bermacam-macam, tapi yang umum kami gunakan adalah masih menggunakan cefazolin 2 gram IV 30 menit sebelum melakukan operasi. Durante operasi, di mana sebagai surgeon kita berusaha meminimalkan stress response karena surgery kita dengan sebisa mungkin menggunakan minimal invasive surgery bila mungkin, tapi pada kasus kami itu total hip biasanya tetap kita menggunakan sistem open ya, bukan minimal, tapi dengan sayatan atau insisi yang lebih kecil kita usahakan. Dan kami menggunakan standar approach posterior, dan kita usahakan juga timing dari operasi juga kita perpendek, baik dari mulai pembiusan sampai selesai surgery diusahakan 1-2 jam, meminimalkan blood loss dengan kontrol bleeding intraoperatif yang teliti, kemudian kita usahakan insisi yang lebih pendek, dan kadang-kadang juga kita memerlukan penggunaan obat-obatan yang sifatnya untuk mengurangi perdarahan seperti tranexamic acid. Yang ini memang studinya juga ada yang sudah membuktikan bahwa penggunaan tranexamic acid ini baik IV intravenus dan juga lokal itu memang menurunkan blood loss. Dan yang terakhir adalah kita menghindari sebisa mungkin penggunaan kateter urin dan juga drain ke daerah luka operasi jika memungkinkan. Untuk postoperatif kita intinya adalah meng-create atau mengusahakan supaya pasien pasca operasi itu bisa mobilisasi dengan sesegera mungkin dan juga pemberian nutrisi yang cepat. Ini bisa dimungkinkan dengan pemberian multimodal analgesia. Ini memang kita berkoordinasi dengan anestesi yang dengan prinsip mereka memberikan multimodal analgesia dan juga menghindari penggunaan opioid karena kita tahu efek samping dari opioid yang udah klasik lah ya, yang lebih dominan untuk meningkatkan kemungkinan postoperatif nausea dan vomiting. Nah, untuk multimodal ini dari mulai saat operasi kita melakukan pemberian infiltrasi lokal ke daerah yang mau diinsisi, nanti waktu nutup pun kita berikan, dan juga saat memasukkan implan. Nah, kemudian dari anestesi memberikan juga obat-obatan untuk mengurangi nyeri atau pain controlnya, dan juga tadi yang kita sampaikan bahwa preoperatif juga kita sudah memberikan analgesia. Biasanya kita memberikan yang kami terapkan adalah pemberian etoricoxib. Jadi 7 hari sebelum operasi. Jadi 1 hari sekali. Kemudian dari bagian nutrisi pas operatif juga akan memberikan oral nutrition sesegera mungkin, dan biasanya kita terapkan pemberian biskuit ya, di recovery room. Kemudian dari anestesi juga mengontrol adanya efek dari postoperasi nausea dan vomiting. Bila memang dilihat ada atau keperluan untuk menggunakan obat-obatan, langsung diberikan. Karena ujung-ujungnya tujuannya adalah untuk mendapatkan mobilisasi yang early dan juga recovery yang lebih cepat. Postoperatif juga kita encourage mempertahankan baseline nutritionnya dan juga status hidrasinya. Dan yang menjadi kata kunci adalah dalam postoperatif eras ini adalah bagaimana kita mendapatkan early dan ongoing mobilization. Sehingga dengan kita bisa melakukan mobilisasi dini, itu akan mengurangi keluhan-keluhan tadi, ya. Keluhan-keluhan tadi akan memulai. Nanti mungkin kita akan bahas itu di belakang, apa yang menyebabkan. Kemudian juga kita mengedukasi pasien juga untuk bisa melakukan activity daily livingnya seperti berpakaian, ya, untuk self care juga. Kita ajar pasien untuk bisa segera bisa mandiri untuk mengerjakan itu semua. Dan bila terpaksa menggunakan kayak kateter urin dan drain, kita usahakan sesegera mungkin juga untuk remove, untuk mempercepat tadi kemungkinan dan bisanya pasien untuk kita mobilisasi dini. Untuk masalah adanya kemungkinan tromboemboli pasca operasi total hip, memang ini ada isu yang besar juga. Tapi menurut data yang kami dapatkan di center kita di Fatmawati, angka tromboemboli pasca total itu rendah dibanding angka untuk Eropa dan Amerika. Nah, maka itu memang tetap kita masih menggunakan guideline dari American College of Chest and Physics ya. Jadi itu dan AOS dari American Orthopedic itu menggunakan obat-obatan, baik itu yang low molecular heparin atau oral dan juga menggunakan mechanical. Tapi yang umum kami gunakan di center kita adalah penggunaan oral Sarelto 10 mg bila kita melihat risiko atau faktor-faktor risiko yang tinggi ada pada pasien itu untuk terjadinya tromboemboli. Nah, untuk studi kami sudah lakukan, sebenarnya angka jumlah pasiennya sudah lebih dari yang ini, cuma yang kami sampaikan ini yang sudah kami hitung secara statistik. Dari ada 30 pasien yang kita lakukan total HIP, dibagi 2 grup, 20 untuk yang diterapkan protokol ERAS dan 10 yang tanpa ERAS. Dengan kriteria inklusi itu adalah total HIP yang pertama atau primary, satu sisi, kemudian preoperatif fitnessnya itu ASA 1-2 dan compliance-nya baik. Nah, yang kami ukur adalah lama operasi, kemudian jumlah blood loss, post-operative pain-nya, satisfaction-nya dengan nanti skala, dan juga berapa lama dirawat atau length of stay-nya. Nah, ini merupakan guideline umum pasien yang akan dilakukan total HIP, di mana pasien ketemu dengan kita di poliklinik, kemudian menunggu jadwal operasi, dilakukan asesmen jantung, internis, dan paru, kemudian bila semua oke, ketemu anestesi, kemudian ketemu lagi menjelang hari operasi, 1 hari sebelum, kemudian masuk rawat dan dilakukan operasi. Nah, yang warna coklat ini adalah tambahan yang kita lakukan bila kita menjalankan protokol ERAS, di mana waktu di poliklinik pertama, pasien sudah kita berikan edukasi mengenai ERAS, kemudian ditambah ketemu dengan dokter rehab medik untuk pre-rehab konsultasinya dan juga dokter ahli gizi untuk menerangkan tentang gizi. Nah, setelah itu ketemu anestesi juga menjelaskan lagi untuk ERAS dari segi anestesi. 1 minggu sebelum operasi pasien kita berikan preventif analgesia, kemudian kita lakukan operasi dan protokol tadi kita jalankan pre, intra, dan juga pasca operasinya berupa masa puasa yang lebih pendek, pemberian carbo loading, ya itu tadi. Nah, untuk secara teknikal operasinya sebenarnya tidak ada yang berbeda antara operasi total HIP dengan ERAS protokol maupun dengan konvensional. Tidak terlalu banyak berbeda secara teknik. Biasa kita menggunakan approach yang standar, kemudian control bleeding juga meticulous. Nah, ini bedanya hanya itu sebelum insisi biasanya kita membuat marking, kemudian kita lakukan infiltrasi dengan markain 0,5% di sekitar luka yang akan kita insisi. Kemudian intraoperatif kita juga melakukan infiltrasi pada daerah sekitar proximal femurnya, di daerah, mungkin kalau orang yang biasa tahu pain management ya, itu di daerah peng kita lakukan penyuntikan di daerah grup daripada proximal femur nerve ya, itu obturator, di situ ada femoral nerve cabang-cabangnya di situ kita blok. Kemudian sebelum kita memasukkan stem dari femur, dan terakhir kita juga memberikan infiltrasi di kulit sebelum melakukan penjahitan kulit. Nah, ini yang tadi yang saya bilang, bila memungkinkan misalnya memang luka operasi tidak terlalu oozing ya, mengeluarkan darah, kita tidak perlu pakai drain dan juga bila memungkinkan tidak memakai kateter urin. Nah, intinya adalah postoperatif adalah bagaimana kita mencapai early mobilisasi. Inilah komponen kunci daripada protokol RS ini, karena dengan mobilisasi yang early ini, komplikasi dan recovery dan juga length of stay akan kita bisa perpendek, dan itu sudah banyak studinya. Dengan bed rest lama, secara teori itu akan meningkatkan resistensi terhadap insulin, terjadi kelemahan otot miopati, kemudian fungsi paru-paru juga menurun, oksigenasi ke jaringan juga terganggu, dan meningkatkan resiko tromboemboli juga. Nah, ini jadi keburukan daripada terlalu lambat untuk memulai mobilisasi. Dan ini sesuai dengan studi daripada Guerra 2015 berupa meta-analisis yang menyatakan bahwa akan terjadi penurunan length of stay yang signifikan bila pasien dalam 24 jam sudah dalam 24 jam operasi dengan melakukan early mobilisasi ya. Walaupun early mobilisasi ini memang sampai sekarang kita tidak bisa menilai apakah memang itu akan ada berhubungan dengan nanti kemungkinan terjadinya dislokasi atau perdarahan yang lebih dan juga loosening daripada implan. Anestesi yang mengontrol nyeri ya pasca operasi, kemudian dari dokter gizi juga merecover status nutrisi dan juga hidrasinya, dan dari dokter rehab untuk melakukan post operatif mobilisasi atau rehabilitasi pada hari yang sama dengan hari operasi. Jadi kolaboratif itu dari anestesi, pain control, kemudian gizi, merecover nutrisi dan juga cairan, dan rehab, early mobilisasi post operatifnya, kesemuanya itu ujung-ujungnya adalah untuk meningkatkan early mobilisasi tadi. Jadi apapun yang kita kerjakan pre dan intraoperatif itu adalah mempromot early mobilisasi. Karena kita tahu tadi kan dengan early mobilisasi banyak hal yang kita bisa cegah. Nah, ini contoh pasien pasca operasi umur 32 tahun, 24 jam pasca operasi. Kita lihat pasien sudah langsung bisa berjalan mandiri dengan memakai alat bantu walker. Mungkin memang ini juga dipengaruhi ya, biasanya umur 32 tahun ini balance-nya baik, balancing untuk kemungkinan jalan dengan baik tanpa jatuh, kemudian muscle power-nya juga baik. Tapi ini kita bisa melihat bahwa dengan protokol RS yang paripurna lengkap, kita bisa mendapatkan pasien pasca operasi bisa early mobilisasi dan mandiri ya. Dan yang kedua ini contoh video dari wanita umur 71 tahun, 3 jam pasca operasi. Ini pindah ke ruang recovery room. Dokter anestesi didampingin oleh kita surgeon mencoba pasien untuk pindah dari kursi roda dari ruang operasi menuju ruang recovery room, mengenai kursi roda. Dari kursi roda kita coba pasien untuk mobilisasi pindah ke bed di recovery room. Ini 3 jam pasca operasi. Jadi dari studi kami itu kami dapatkan bahwa secara lama operasi, kemudian jumlah perdarahan itu memang terjadi penurunan dengan ERAS, tapi secara statistik belum signifikan. Nah, yang secara statistik signifikan yaitu adalah lama rawat atau length of stay. Kita dapatkan penurunan lama rawat, kemudian postoperatif pain-nya juga menurun menggunakan numeric scale, dan yang terakhir adalah penurunan atau peningkatan kepuasan pasiennya. Yang kita menggunakan Likert scale ya. di mana sangat puas ya. Itu kita melakukan penilaian, didapatkan juga hasil yang signifikan dengan meningkatnya Likert scale-nya ya. Jadi kita dapatkan 3 outcome yang secara signifikan klinis dan statistik bermakna, yaitu lama rawat, kemudian nyeri, dan kepuasan pasien sendiri. Nah, dari itu kita menganalisa juga dari studi-studi yang lain, memang didapatkan seperti Stower juga mendapatkan yang sama, bahwa terjadi penurunan length of stay. Kemudian Emailman juga mendapatkan penurunan length of stay dari studi mereka. Untuk pain juga ada studi dari Kirstelis juga mendapatkan improvement dari pain score-nya. Dan dari segi kepuasan pasien dengan Likert scale tadi, studi yang sama, Kirstelis juga mendapatkan kepuasan yang lebih pada pasien yang menggunakan protokol ERAS. Nah, sebagai take home message, ERAS ini bukan teknik operasi ya, jadi ini adalah multi modality atau multidisciplinary. Kita spesialis, beberapa spesialis untuk melakukan sebuah protokol yang kita sudah tetapkan bersama untuk tujuan mencapai outcome recovery dan juga kepuasan dari pasien pasca operasi. Dan menurut kami protokol ini masih terus akan kami perbaiki, kami optimalkan untuk bisa mendapatkan hasil yang lebih baik lagi. Dan menurut kami ERAS teknik ini tidak hanya bisa dilaksanakan untuk operasi hip ya. Kalau di luar kan hip dan knee itu udah lazim, tapi juga menurut kami bisa dilakukan untuk operasi ortopedi yang lain. Karena memang hasilnya baik, dan seperti kita Fatmawati ya, memang bersyukur kita lengkap spesialis-spesialisnya ya. Alangkah baiknya kita bisa coba untuk laksanakan, karena ini ujung-ujungnya untuk keselamatan dan kepuasan pasien kita juga. Terima kasih atas atensi dan kesempatan yang diberikan. Kami kembalikan kepada moderator.
Akan dipresentasikan oleh saya sendiri. Jadi kita akan menjembatani mengenai hip replacement dan hip arthroscopy dengan topik dan mengenai hip preservation concept. Oke. Jadi mengenai hip preservation concept sendiri adalah tidak semua hip itu harus dilakukan replacement. Jadi outline-nya sendiri adalah mengenai sedikit mengenai hip arthroplasty, kenapa dia sangat sukses, apakah semua hip itu mesti dilakukan penggantian sendi, dan apa negatifnya dari hip replacement itu sendiri. Dan kenapa kita mulai beralih kepada hip preservation, tidak semuanya mesti dilakukan replacement, tetapi untuk topik kali ini saya tidak akan menyentuh mengenai hip arthroscopy karena nanti akan di-cover oleh Prof. O'Donnell. Oke. So, teman-teman sendiri mungkin udah cukup mengenal residen mengenai hip arthroplasty itu apa. Jadi basically untuk hip yang arthritic, yang AVN atau misalnya dia ada fraktur pada kolom femurnya, kita bisa melakukan penggantian sendi panggul. Jadi baik dari cup, head maupun dari neck femurnya sendiri bisa kita gantikan dengan stem, dan hasilnya sendiri cukup baik, terutama untuk teman-teman yang awam yang masih belum tahu mengenai hip replacement. Kurang lebih beginilah gambar atau ilustrasi dari hip replacement itu sendiri. Teknik kan macam-macam, tapi intinya adalah sama, tugasnya adalah menggantikan sendi panggul yang sudah rusak menjadi sendi panggul sintetik atau buatan, artificial, yang sifatnya dia halus dan tidak sakit lagi. Dan ini artikel yang sangat terkenal, dipublish di Lancet tahun 2007, yang mengatakan bahwa hip replacement adalah operation of the century. Jadi di abad 1900 sampai 2000 ini adalah inovasi yang cukup sangat-sangat baik, yang cukup mengubah tata laksana untuk pasien-pasien dengan hip arthroplasty, dengan hip masalah pada hip. Kenapa demikian? Karena dari hasil yang didapatkan oleh total hip replacement ini, pasca 1 tahun, hampir 96% pasien merasakan puas. Jadi outcome-nya sangat-sangat bagus, di mana pada awal tahun 1930, 1960, mereka masih berusaha menggunakan teknik-teknik operasi yang osteotomi, kemudian di interpositional arthroplasty dan lain-lainnya, nih hasilnya kurang memuaskan untuk pasien. Tetapi tahun 1960, Chanley secara kebetulan membuat hip arthroplasty dan hasilnya sendiri dia sangat baik, dan inilah menjadi awal dari kita semua melakukan hip replacement pada semua pasien kita. Oke, ini slide tadi Dr. Jamal sudah sampaikan, jadi pasien kita hasilnya sendiri sangat bagus. Yang pertama ada pasien 66 tahun, hari ke-0 sudah bisa dapat berdiri. Dan pasien yang kedua, kita nggak bisa, tadi sudah sampaikan video Dr. Jamal, 3 jam post-op sudah bisa pindah dari bednya begitu anestesinya hilang. Dari pindah ke kursi roda sendiri, dan dari kursi roda dia pindah ke bednya sendiri. Jadi early mobilization sangat bagus. Jadi, nah muncul pertanyaan kepada kita semua, ya udah, kenapa enggak semua masalah hip kita replace aja kalau hasilnya sedemikian bagus? Ya. Dan in the end, masalah utama dari hip replacement adalah implant survival. Jadi yang dibilang implant hip itu permanen seumur hidup, enggak. Dia ada lama waktunya, dan lama waktunya itu akan jadi masalah di kemudian ke depannya. Jadi survival pada total hip sendiri, another article from Lancet, jadi dikatakan survival sendiri 90% pada 15 tahun. Tapi kita bisa interpretasikan 10% dari pasien kita operasi pada 15 tahun akan mengalami revisi. Dan hal ini akan meningkat pada 20 tahun, sekitar 30% akan mengalami revisi. Dan sampai 25 tahun, hampir 43% mengalami revisi. Jadi hampir sebagian akan direvisi mengenai di titik 25 tahun. Dan bagaimana kalau misalnya pasien itu adalah pasien usia-usia muda, pasien usia 20 tahun, pada usia 45 tahun dia akan dioperasi lagi. Dan kemudian pada usia 50 atau 60 tahun akan dioperasi lagi. Jadi hal itu akan jadi masalah ke depannya. Kemudian resiko untuk revisi terapi ini akan meningkat seiring dengan usia. Jadi pada pasien-pasien usia muda yang sangat aktif, dia akan mengalami resiko lebih tinggi, lebih awal mengalami revisi. Contohnya pada pelari ini, dia ada pelari maraton, 3 bulan setelah operasi dia menamatkan Ultraman dengan artificial hip. Jadi bisa dibayangkan berapa lama lagi hipnya akan mengalami revisi. Oke, we don't know, we'll see. Oke, dan revisi, dan bagaimana apabila setelah dilakukan revisi, berapa lama sih hip replacement itu akan bertahan? Dan angkanya ini akan terus menurun pada revisi pertama, kedua, dan ketiga. Jadi pada revisi pertama, sekitar 20% akan mengalami revisi dalam 15 tahun. Revisi kedua, sekitar 20% akan direvisi lagi dalam waktu 7 tahun. Dan pada revisi ketiga, akan direvisi lagi dalam waktu 3 tahun. Jadi dilihat patternnya sendiri, dia dibagi dua. Semakin singkat. Mungkin revisi keempat cuma 1 tahun. Dan ngomong ke pasiennya gimana, apakah setiap 1 tahun mesti dioperasi? Kesian juga pasiennya. Oleh sebab itu, mulai muncul konsep mengenai hip preservation. Jadi kita try to preserve the natural hip, dan biasanya kita indikasikan pada pasien-pasien yang usia masih muda. Jadi apakah semua pasien mesti kita preserve hipnya? Iya, tapi enggak semuanya. Jadi kita tujukan hip preservation ini pada pasien-pasien usia muda, dan pasien-pasien yang minimal atau non-arthritic. Kenapa? Karena begitu ada tanda-tanda arthritic, the outcome is not very good. Jadi istilahnya, begitu kita lakukan preservation, begitu ada arthritic 2-3 tahun bakal dilakukan replacement. Jadi technically nggak ada gunanya. Oke. So ketika kita melakukan hip preservation surgery, kita harus memilih pasien kita yang cocok yang mana. Kenapa? Karena kalau misalnya cuma 1-2 tahun kemudian dilakukan replacement nggak ada gunanya. Kita mau 5, 10, atau 15 tahun pasiennya bisa kita delay. Ya. Jadi ideal candidate-nya adalah young and active adults, no autoimmune arthritis. Dan indikasinya apa? Labral tear, nanti kan kita bahas lebih dalam. Hip impingement atau kita kenal sebagai FAI. Hip dysplasia, selama belum ada arthritis, ya kita bisa lakukan preservation surgery untuk dysplasia. Dan AVN yang masih grade awal. So, mengenai hip preservation konsep ini diperkenalkan pada tahun 1880 ketika mereka mulai menyadari masalah-masalah yang muncul pada saat setelah THR. Jadi mulai ada 20 tahun sejak Chandra menemukan THR, mulai dirasakan revisinya kok mulai agak banyak. Jadi kita mesti menjawab masalah ini menggunakan hip preservation surgery. Dan lucunya, semua teknik yang dilakukan pada saat itu adalah pengulangan dari yang dilakukan sudah pada tahun awal abad 1900-an. Dan dikembangkan lagi mulai pada abad 2000, yang paling menjanjikan adalah pada tahun 2004-2005 oleh Profesor Gans. Jadi dia menemukan teknik mengenai safe surgical dislocation of the hip. Jadi bagaimana cara mendislokasikan hip ke anterior tanpa merusak aliran darah ke panggul. Jadi resiko AVN-nya sendiri sangat kecil. Kemudian dari teknik tersebut dikembangkan mengenai teknik-teknik lain, intracapsular osteotomy, previous acetabular osteotomy, itu untuk dikembangkan oleh Profesor Gans juga, jadi acetabulumnya di realign sehingga coverage dari acetabulumnya meningkat, dan juga mulai berkembang hip arthroskopi, ya salah satu pionirnya nanti akan berbicara di topik ketiga. Nah, ini adalah contohnya untuk survei, jadi kasusnya Dr. Faisal, jadi pediatric slip upper femoral epiphysis, di mana kaput femurnya sendiri mengalami slip, dan kita lakukan realignment osteotomy untuk mempertahankan dan realign dari hipnya sendiri supaya tidak mengalami OA ke depannya. Dan ini dikembangkan oleh Profesor Gans, major workhorse untuk operasi hip dysplasia. Jadi kita melakukan triple osteotomy, tetapi posterior column tidak dipatahkan secara komplit untuk realign bentuk dari acetabulumnya, di mana acetabulum awalnya kita lihat di sini kelihatan lebih dangkal daripada biasanya, dan dilakukan osteotomi pada ilium, pubis, dan sebagian dari ischiumnya, dan di realign bentuknya dan dilakukan fiksasi sehingga coverage dari acetabulum meningkat dan risiko OA-nya akan menurun dengan drastis. Ada lagi, Profesor Gans juga menemukan safe surgical dislocation of the hip. Nanti teman-teman yang residen mungkin akan belajar mengenai hal ini, dan ini sangat penting untuk kasus-kasus fraktur pada head femur, atau misalnya kasus-kasus kita melakukan osteotomi pada neck atau pada head. Dan teknik ini dikembangkan juga oleh Prof. Sugioke dari Jepang, dilakukan rotational untuk AVN, tapi terus terang it is a little bit well-known consensus that teknik ini tidak dapat dikerjakan di luar Jepang. Jadi kita sudah mencoba melakukannya, tapi sepertinya hanya orang Jepang bisa melakukan hal ini. Amerika pun nggak bisa. Who knows? Oke. Dan ini adalah contoh application dari safe surgical dislocation of the hip. Jadi kita ada kasus mengenai femoral impingement, di mana ada dua tipe, cam dan pincer. Cam itu sendiri adalah bentuk dari femoral head-nya tidak spherical, dan bisa kita lakukan teknik ini untuk membentuk kembali, ya, yang awalnya bentuknya tidak bulat, tinggal kita bentuk, kita bor, kita shape lagi bentuk dari femurnya, jadi bentuknya seperti bulat lagi. Jadi ada alat untuk secara objektif kita bisa menilai ini udah benar-benar hemispherical atau belum. Oke. Tetapi hal ini sudah mulai agak ditinggalkan dengan munculnya teknik arthroskopi. Ya. Lagi-lagi saya nggak akan bahas arthroskopi di sini, nanti akan Prof. John akan membahasnya. Dan juga ada tipe yang kedua dari FAI adalah tipe pincer. Ya, kalau cam itu adalah tipe di femoral head-nya, pincer itu adalah tipe di acetabulumnya. Jadi acetabulumnya terlalu nonjol, terlalu banyak yang muncul keluar. Jadi kita lakukan operasi untuk mengikis bagian yang menonjol keluar tersebut sehingga bentuknya kembali normal. Dan ini ada yang dinamakan sebagai labrum, ya, dia semacam fungsi sebagai tanda kutip agak sebagai bantalan. Dan ini yang mesti kita lakukan repair atau refiksasi. Oke, jadi kita bahas sedikit mengenai labrum. Jadi fungsi labrum itu sendiri adalah memaintain tekanan negatif pada hip. Apa itu tekanan negatif? Nanti akan kita bahas. Dan juga dia fungsinya adalah menjaga suction seal. Jadi dengan ada suction seal tersebut, tekanan negatifnya dia akan ada. Oke, bisa di-play videonya? Coba dengar suaranya. Ini jadi yang awal adalah kondisi ketika labrumnya intak. Bisa. So, ada suara nggak Pak? Oke, ini kalau kondisi pada labrumnya robek, sudah diangkat sebagian, bisa diulang di awal aja. Oke. Oke, ini pada kasus labrum masih intak, ditarik seperti itu pun susah keluarnya. Dan tekanan yang hebat, pop bunyi biasanya. Dia baru keluar. Tapi labrum kita angkat, gampang banget keluarnya. Tekanan negatifnya nggak ada, jadi dia langsung bisa gampang keluar. Dan begitu kita repair atau reconstruct, balik lagi, walaupun nggak sebagus aslinya. Ya. Nah, dan ini adalah studi yang sangat bagus dari Terayama di New England Journal of Medicine tahun 1980. Dia melakukan slicing pada spesimen anatomis dan menemukan bahwa sendi panggul itu berarti cartilage di acetabulum dan femurnya tidak menempel. Dalam posisi diberikan beban pun, bahkan 2 kali di beban tubuh kita, masih ada celah di sini sekitar setengah mili. Ya, dia nggak akan menempel. Kenapa? Karena fungsi labrum di sini adalah menjaga supaya ada cairan sendi di dalam sendi panggul ini tidak akan keluar. Fungsi sebagai suction seal, dia menahan semuanya cairan keluar, dan cairan ini yang fungsinya mentransmisikan beban ke semua sendi panggul. Jadi beban di panggul itu enggak terfokus pada bagian superior dome aja, tapi ke semua sendi panggul karena ada mekanisme ini. Dan ini di-publish lagi, di studi ulang lagi oleh Ferguson, dan mereka menemukan tekanan apabila strukturnya labrum masih ada, tekanannya rata semuanya di sepanjang acetabulum dan femoral head. Akan tetapi begitu labrumnya hilang, labrumnya nggak ada, tekanannya mayoritas di bagian superior. Dan inilah fungsi dari labrum itu, dan kenapa labrum itu penting. Karena fungsinya sendiri menyangkut OA ke depannya. Dan kita bisa bayangkan begitu labrum nggak ada, tekanan fokus di bagian atas superior dome ini, in the end, kejadian adalah seperti ini. Awalnya ini adalah case report di mana pasiennya dilakukan labral debridement. Awalnya dia masih lumayan, joint space-nya masih lumayan ada. Post-op, labrumnya diangkat di debridement, dan 1 tahun setelahnya joint space-nya nggak ada lagi. Jadi mengalami OA dengan cepat begitu labrumnya hilang. Jadi dengan adanya labrum kita bisa menjaga supaya hipnya sendiri lebih normal dan hip arthritis bisa dicegah, dan kita bisa mencegah terjadinya dilakukannya hip replacement. Dan penanganan sendiri dari labrum itu mudah mulai berubah. Yang awalnya kita lakukan debridement saja karena dianggap labrum sebagai pain generators, jadi bisa kita angkat. Tapi dengan studi-studi yang tadi sudah ada, ternyata enggak, labrum itu penting. Jadi kita mulai ke arah repair. Dan apabila tidak dapat kita repair, kita lakukan reconstruction. Jadi sekarang arahnya ke sana, mungkin bisa ke depannya ke arah stem cell, but who knows? Maybe John will explain about this later. So the labral reconstruction juga diindikasikan kalau labrumnya very severe damage, atau misalnya labrum hypertrophic di mana fungsi labrumnya udah nggak ada lagi, atau labrumnya sangat kecil atau misal kasus di mana labrum repairnya gagal. Jadi kita bisa lakukan labrum reconstruction dan in technical demanding and also very expensive. Oke, jadi in the end sebelum kita tutup, apakah hip replacement surgery dapat mencegah terjadinya hip replacement? Jawabannya iya, tetapi kita mesti memilih pasiennya dan kita juga mesti memilih tindakan yang cocok untuk pasiennya. Jadi ada dua tindakan yang paling sering digunakan untuk hip restoration ini adalah satu hip arthroscopy dan yang kedua adalah Gans osteotomy untuk displasia. Untuk hip arthroscopy sendiri rata-rata dikatakan mereka bisa rate of conversionnya kedua-duanya adalah di bawah 10%. Dan untuk hip arthroscopy dia bisa mendelay kurang lebih sekitar 24 sampai 48 bulan. Sementara untuk PAO untuk Gans dia juga rate of conversionnya 10%. Tapi dia bisa mendelay lebih lama sekitar 5 tahun, 6 tahun, 72 bulan. Oke. Dan jadi angka untuk reservasinya cukup baik apabila dilakukan dipilih pasiennya, patient selection juga baik. Oke, so that concludes my presentation. We try to save our hips whenever possible. And thank you. And so for the next speaker, I would like to invite my mentor and the one who introduced me to the hip arthroscopy, so Professor John O'Donnell. So Professor O'Donnell, he works in Melbourne, Australia, and he works in his own clinic in hip arthroscopy Australia, and he practiced at the St. Vincent General Hospital where he operates there. He was the past president of ASIA, which is the International Society of Hip Arthroscopy. We know that it is a International Society of Hip Restoration right now. And he's also the founding father of the ASIA as well. So maybe a little brief introduction about Professor John O'Donnell. Okay, then he will present to us about the hip arthroscopy, about the past, present, and the future. Okay, for John O'Donnell, the time is yours.
Thank you, Yoshi. Thank you very much. Thank you so much for inviting me to be a part of this presentation. It's a great honor and great pleasure for me to be part of it. My only disappointment is that I'm sitting in Melbourne and not with you instead. However, that will change one day, I'm sure. I'll just share this now and get this started. So I would just like to thank you for that really excellent introduction and discussion of the role of hip preservation surgery. There was nothing that was said that I would disagree with, and I think it was done beautifully. So really all I have to do now is carry on and show how some of this, and much indeed of it, can be performed arthroscopically. But of course, all of these surgeries can be performed open as well, with really excellent results. The big advantage to performing them arthroscopically is the speed of recovery and shorter time in hospital. So I work in Melbourne, which that's it on a nice day, which indeed today is. And this is the hospital, St. Vincent's Hospital in East Melbourne, where I work, and where these days all I do is arthroscopic hip surgery and nothing else. There's no important disclosures that I need to make that are relevant to this presentation. So I'm sure you'll recognise some of the people here. So this was the International Society for Hip Arthroscopy meeting, which occurred in Melbourne in 2018. And there's a fine Indonesian contingent present over to the right-hand side of the screen. But we had an Asian day before the main part of the meeting, which was, you can see, well attended, and was a wonderful, wonderful day. So I've been asked to talk about a little bit of how hip arthroscopy came about. What are the things that we can do arthroscopically now, and what things may be coming up in the foreseeable future. I think many people are aware that arthroscopic or hip arthroscopy was first described by Dr. Michael Berman in the US in 1931. However, it's cheating a little bit to say that this was the first hip arthroscopy, because all of Dr. Berman's arthroscopies of various joints were performed on cadavers. And the hip arthroscopies at this time were purely done on cadavers. And it should also be noted that Dr. Berman stated that it was manifestly impossible to arthroscope the hip, but that's because he did not use traction. Quite when clinical hip arthroscopy started is a little unclear. Dr. Einar Eriksson in Sweden performed his first in 1972, and I think it was around about that time that this operation started. The first one that was performed in Australia, we do have a definite time for, that was 1978. And it was done in the little town of Launceston in Tasmania by Dr. Bernie Inoda, who you can see here. And the instruments that he used, which are shown in this slide, he made himself in his back shed on the week before the operation. There were no hip arthroscopic instruments. They were all homemade. We owe a lot to this man, Dr. James Glick, who along with Tom Sampson published the lateral approach to the hip for hip arthroscopy in 1987. In the earlier days of hip arthroscopy, many of the major hip surgeons, particularly those in England and some of the earlier in the US as well, and still by surgeons such as myself, we perform the operation with the patient positioned laterally, as seen in this picture. Dr. Glick found it much easier in those early days to actually get into the hip with the patient positioned laterally. When I first started performing hip arthroscopy in 1992, I did them with the patient supine because that was really the only system that we had available to us. And this is how we used to do it back in those days. We used a standard fracture table. We put a lot of extra padding on that post that went around the perineum and tried very hard to avoid direct pressure onto the perineum because of the problems with nerve palsies that occurred in those days. And the patient was positioned on their back, and the instruments were then held out the side, as you can see here. And they were much longer instruments then and quite crude. And there was a bit of a tendency for them to fall out and drop on the floor. There was no training available because there were very few people who actually did the surgery. I read Dr. Glick's paper, and I had some advice from one of my mentors who had performed 2 hip arthroscopies in his life and told me he thought it was a really bad idea anyway. But we went ahead and started and continued. So back in those days, in the early 1990s, there were very few indications we could see in the hip, and these are pictures taken at that time, but about all we could treat were labral tears, chondral lesions, and loose bodies. The instruments you see on the tray were the full set that we had available apart from the shaver, and most of these were homemade at that time, although not in my back shed, but rather by equipment companies. But the instrumentation was extremely limited. We had no anchors available to treat labral tears at that time. We had to use shoulder anchors, and these were not really suitable, but that was all we had. Things really changed with the work of Gantz, as has been talked about already, that FAI, although that was a new term at that time, femoroacetabular impingement, the concept had been around for a long time. And indeed, the first written description I can find of it was the book in German on the left, published in 1913. But the work published in 1936, which you'll see here, and that actually described impingement and the operations which are illustrated there in a crude form, operations for pincer impingement and cam impingement. And that was published way back in 1936. It was the work of Gantz and others in Bern, however, that really changed our understanding of this and greatly enlarged the whole concept of femoroacetabular impingement. And today we talk about a normal hip, a hip with a cam lesion or excessive bone on the femoral head neck junction, causing a focal bump, or pincer impingement with overgrowth or overcoverage of the acetabulum, which may be either global or focal. So the whole acetabulum or just a part, or it may be a mixture of both of these. There are other forms of impingement as well, such as ischiofemoral impingement, trochanteric impingement, and others. But these are the two forms and the mixed form of femoroacetabular impingement. This was a time which was really quite exciting back in the early 2000s because there were very few hip arthroscopy surgeons around the world. We felt very threatened by other hip surgeons who felt that what we were doing was wrong and shouldn't be done. And this was the second international hip meeting that was held in Cambridge just in 2003, so only 20 years ago. And most of the major hip arthroscopy surgeons in the world were at that meeting and are in this picture, obviously looking very much younger than any of us do today, unfortunately. And then in Paris in 2008, 12 of us formed the International Society for Hip Arthroscopy, and this is all of those people back at that time. I would strongly encourage any of you who have an interest in hip arthroscopy to join ISHA and where possible to come to the annual meetings, as these are just a wonderful place to meet other hip arthroscopy surgeons, but also to learn what things are happening in the world of hip arthroscopy, what developments are taking place, and to be really at the forefront of this surgery. So by 2010, you can see our list of 3 indications has expanded fairly dramatically, so that now we're performing surgery within the hip joint, the actual intra-articular portion of the hip or central compartment, which you can see illustrated up here, but also in the peripheral compartment, which is the part outside the joint, but still within the hip capsule, and also the extra-articular area around the hip joint where we can operate on the soft tissues, still with the same endoscope or arthroscope, and avoid, in many cases, open surgery to perform such things as gluteal tendon repairs, psoas tendon lengthenings, piriformis release and sciatic nerve decompression, hamstring tendon tear repair, and removal of heterotopic bone. But there are many, many other indications now. Many people in Australia, at least, regard hip arthroscopy really as a treatment for femoroacetabular impingement. But you can see there is way, way more to it than that. So in January 2020, I did my 10,000th hip arthroscopy. So you can see there's plenty of indications around if you look. And there are variations from country to country. I'm not sure how much of this is genetic and how much is cultural, related to the type of activities that particularly young people perform in these countries. It's always said that femoroacetabular impingement is much less common in Asian countries and dysplasia is much more common. But I suspect that as activities change, this may change as well. So what are the sort of things that we can do? So we talked about removal of the excess bone due to a cam lesion. And you can see an example of that here, where on the CT scan at the top left, there is a protruding piece of bone, which is what causes impingement. That same bone is seen beneath at the arthroscopic picture, this being the same one. And the removal of the bone, which was just showing on the video, is then performed arthroscopically to reshape the upper end of the femur. We can also treat labral tears, and here's a good example of a torn anterosuperior labrum. And what we do is prepare an area on the rim of the acetabulum so that there's a bleeding area of bone to reattach, because that area of the labrum is almost avascular due to the tear. And then we insert anchors, which in this case are all suture anchors. The limbs of the stitches are passed either through or around the labrum, and the labrum is sutured back into position as seen at the bottom right corner. We try as much as possible to pass the stitches through the labrum rather than around, and use smaller and smaller instruments, as you can see here, to catch the stitch. We have seen, rarely but occasionally, in patients where the stitch has been passed around the labrum, that it has then caused some abrasion of the articular cartilage on the femoral head. And so it is nice to keep the stitch out of the way of the femoral head articular cartilage as much as possible. Of course, sometimes the labrum is small or delicate, and it is simply not possible to do that. My apologies. Some people will not stop ringing me up. However, the one thing we can treat that you really can't treat very well open is damage to the teres ligament or ligamentum teres, which you can see here on the left. So that's a partial thickness tear of that ligament, but you can't assess that by open surgery, as in order to dislocate the hip, you have to cut that ligament in its entirety. Now, in many cases, that probably doesn't matter, but in cases where there is some instability of the hip, it certainly may matter a lot. And so you can see how we treat such an injury here, where on the top right, we've used a radio frequency probe to debride the torn sections of the ligament. And then in order to protect it and deal with the underlying mild instability which has led to that problem, we placate or stitch the anterior capsule of the hip joint in order to tighten it, to slightly lessen the degree of external rotation that is available and to better stabilize the hip. We found that by doing that, we cut the rate of recurrence of these ligament tears from nearly 25% to less than 3% over a 5-year period. But we can also treat things outside the hip. So this is a tear in the gluteus medius tendon and gluteus minimus as well at the greater trochanter, which we've treated by placing, by decorticating a little of the bone to get a bleeding surface, placing anchors, and then suturing the tendons back into position and closing the defect. I use this for smaller tears, but for really large tears, I still use open surgery, as I find I can much better place transosseous sutures, which I like to do for these repairs, but also do transfers when necessary, be that the fascia over the vastus lateralis or moving part of the gluteus medius and gluteus maximus tendons. This is division of a psoas tendon immediately above the attachment at the lesser trochanter. This is much more commonly done for pain of psoas tendonitis following hip replacement than in people who have not had a hip replacement. In those without a hip replacement, the psoas tendon can be an important stabilizer of the hip joint. We try very hard to avoid cutting it. But after hip replacement, this is a very different situation. And we find, and it's been suggested that psoas tendon pain after hip replacement may occur in around 3 to 4% of patients. It's often ignored, but it can be very easily treated and well treated. And this operation regularly leads to excellent relief of pain and, surprisingly, no loss of strength around the hip. I would certainly expect some loss of strength, but in fact, in most cases, we find patients feel stronger because the pain that was present before and which inhibited their muscle strength is gone. And indeed, the very first patient I performed this operation on, I went to see him afterwards, having warned him of the likelihood of some weakness around the hip. And in fact, he was walking without aids, He'd just been up and down the stairs, and he said to me that this was the first time he'd been able to climb stairs in 3 years, and that was 4 hours after the surgery. What are the areas that we're currently working on to improve the surgery and further develop it? And I think the 3 major areas right now that are most developing are microinstability or instability of the hip, labral and ligamentum teres, and capsular reconstruction. So reconstructive surgery and treatment of instability. I think it used to be said, and probably still is a lot, that the hip is a very stable joint, not like a shoulder, and instability, short of dislocation, is really not an issue. That's not true, and microinstability, or more minor instability, is certainly a problem that we see, and I imagine you would too, with the increase in joint hyperlaxity seen in your populations compared to ours. Some nice work has been done on microinstability on ballet dancers, of course, because they are asymptomatic often, although sometimes they're symptomatic and just don't admit it. And there was one study, you can see on the left, with a small ballet, very mobile ballet dancer, you can get them into an anterior splits position and feed them into an MRI machine in that position and demonstrate subluxation of the hips that's present in them. Or you can do this with X-ray, as seen on the right. And again, this was in asymptomatic ballet dancers. And you can see that in a lateral splits position, the femoral heads subluxate and indeed even lead to the presence of a vacuum sign, which occurs with that subluxation. So movement of the femoral head within the acetabulum, other than just the normal rotation, is real, and it can be increased, and that can lead to problems which can be treated. Of course, bony instability is generally best treated by periacetabular osteotomy, as you have already seen, but in some more restricted cases, it may be sensible to consider a shelf arthroplasty, and this can be performed arthroscopically, as you can see in these examples from Dr. Soshi Yoshida in Japan, where an area on the side of the pelvis is decorticated. You can see down here the capsule of the hip. A piece of bone, which is cut from the iliac crest, is then placed over the capsule of the hip and applied to that decorticated area, and then held with 1 or preferably 2 screws. And this can have good outcome in carefully selected people. But again, I would emphasize that I think the majority of people with dysplasia should be treated, if they're going to be treated operatively, with a periacetabular osteotomy. You've already seen an example of this with the stability of the hip, which is associated purely with the labrum. And so damage to the labrum is extremely important for a lot of reasons, but particularly for cartilage nutrition and also for maintenance of stability in the hip. So when an area of the labrum is missing, and in my experience, that's mostly because a surgeon has removed it, then it can be replaced. And in this case, it's with a piece of iliotibial band, which has been rolled up into the shape of a labrum, but other tendons can also be used. And in this situation, that segment of missing labrum has been reconstructed using that tendon. And we've found the outcomes from this surgery have been really excellent in people who were struggling with hip pain and instability after labral injury. The entire labrum can be reconstructed arthroscopically. This is a picture from Dr. Brian White in Colorado. And he routinely, rather than doing a segmental reconstruction, reconstructs the whole labrum, as you can see here. And indeed, he does it a lot, far more often than I ever have, but with really excellent outcomes, surprisingly excellent. We can also reconstruct the ligamentum teres, which is something that we do infrequently. I think I've done that around about maybe 25 or 30 times in my life so far. So you can see in the top left where there's the femoral head, there's scar tissue present in the acetabular fossa, but no ligament in between. So we can prepare a bed for the ligament reconstruction, scraping away that scar and fat and getting a prepared bony bed. We drill a hole through the femoral neck, exiting at the site of the normal ligament attachment. And then we work through that hole to place, to place anchors at the acetabulum. Some people use an endo button. I prefer anchors. And then having placed those anchors with the sutures passing up through the tunnel in the femoral neck, we then slide the graft, which usually is allograft, either tibialis posterior or anterior tendon, but can be hamstrings or can be autograft for that matter. Slide that down the neck and into the acetabulum, fix it with the anchors, and then place an interferon screw in the femoral neck to fix the graft within the femur. We found excellent outcomes with this procedure, but it's usually done for instability with an absent ligamentum teres. For those who have ligament injuries associated with overcoverage or with cam lesions, this type of surgery is not required because they don't have any significant instability at that time, which requires treatment. What are the areas where we're still really struggling? The major one is cartilage repair and regeneration. So we currently use microfracture and autologous matrix-induced chondrogenesis, or using a collagen patch to cover an area of microfracture. We can repair, to a degree, debonded articular cartilage, as seen here, where we use microfracture and fibrin glue. And although it's been shown that these flaps of cartilage are not normal, they do heal and seem to recover well and give good long-term outcome. Of course, it is really important to deal with the cause of that problem as well, which is almost always a cam lesion, so that has to be fixed at the same time. So this is an example of how that might be done. You can see we use the golden microfracture pick to make holes under the surface of the cartilage. We inject fibrin glue and then take the traction off, and the femoral head will push the cartilage back into position. And with small lesions, this works well. With small areas of cartilage loss, microfracture we've found to be very efficient and satisfactory also. So it seems to work better than in the knee. So here you see what happens when we remove the pressure of the fluid and get bleeding from the microfracture holes. And one example on the left of a microfracture 4 years after it was done, when we were repeating the arthroscopy for an unrelated injury, for a separate injury. And on the left, 6 years after, for a slightly larger lesion, where the areas of healed fibrocartilage are maintained very well after this length of time, and indeed for a lot longer also. However, slightly larger lesions, we can use a collagen patch to cover and again extend the indications for this type of surgery with good outcomes. But larger lesions, we have no good way to treat, and indeed this one is heading for a hip replacement. There may be ways that we can improve this using stem cells, perhaps tissue engineering or genetic manipulation, and certainly lots of work is being done on that right now. But at this stage, we really don't have a good way to deal with those larger lesions, and my experience of stem cells has not been encouraging. So that's where we are now, but I think we have many things that we can do arthroscopically with excellent outcomes. And I would certainly strongly encourage you to look at this type of surgery amongst your armamentarium for treating hip conditions. Thank you very much.
Thank you very much, Professor John. A very wonderful lecture because I think it's very beneficial to us, for the young surgeon, and also for the resident, about the exposure of the hiposcope, especially for the specialist lesion like the micro instability and ligamentum teres as well, because I think it's important to get an exposure around that area. So the next session will be the discussion, which will be held in English. So if there is any question from the floor, from all three speakers, please just ask and we'll try our best to answer it. Okay. Yes, please.
Good afternoon. Thank you for the opportunity. My name is Winona, and I would like to thank all the speakers for the presentation. My question is for Dr. Jamot, the first presentation regarding the ERAS protocol implementation in orthopedic surgery. It was explained that the implementation of ERAS protocol in orthopedic surgery is relatively new topic to be implemented. My question is, what are the hindrance or the obstacles in implementing the ERAS protocol in orthopedic surgery? And my second question is that can the ERAS protocol be implemented in all patients of orthopedic surgery? And regarding the BPJS and the administration and regarding that topic. Thank you, Doctor, for the opportunity. Good afternoon.
Okay, Dr. Jamot. There's a question about the ERAS, about the obstacles, and when we try to begin the procedure, what's the hindrance of the program? Okay. Hambatan ketika.
Thank you. Can you hear my voice, Dr. Yosi?
Yes, loud and clear.
Can you hear my voice?
Yes, yes.
Okay. Okay. Thank you. So for the ERAS protocol, I think we just start using this about the last 3 years in our hospital. Maybe not because so many kind of obstacle, but maybe the problem is it's quite difficult for us to start. So, and also because this protocol must be run by multidiscipline of the specialty. So we have to collaborate with anesthesia, rehab, and also the dietary. So I think we can start the simple one by using the committee in your hospital. You start make a protocol that you have to address, and also you try to make the simple one. As long as the protocol, the aim is to get the early mobilization and a good outcome and recovery. And also, I think there is no relation with the BPJS or national insurance, because maybe the problem is we have to give more effort, like the rehab, dietary, and also the anesthesia must have more effort, because we have to see the patient, educate the patient before surgery, maybe 2 or 3 times before surgery. I think the problem is only about that, not regarding to the fun or affordable of the patient, because I think the procedure is quite same, but seems more complex because it involves another specialty, not only the surgery. Thank you, Dr. Yosi.
Okay, thank you, Dr. Jamot. Maybe I would like to add something to the answer, because the main reason the ERAS is a little bit difficult, because we as a surgeon tend to have our safe zone, our zone of comfort, and we tend not to leave that zone of comfort, because when we try to ERAS, we're trying something new. Sometimes we don't feel comfortable in leaving our safe zone. So, and that's the main reason, the main obstacle of doing that. So when we do the ERAS thing first, we make our little team of this 2 orthopedic surgeon, 1 anesthesiologist, 1 rehabilitation specialist, and 1 the nutritionist, and we start by ourselves. the high level management doesn't really know about it. So when we started, yeah, it's a little bit much effort when we try to do that. And also regarding the funds, I know that there is many hospitals in Indonesia that add an extra cost if you want to be operated on FS, but that's not exactly true, because when you apply the EFS concept, the price is significantly lower because the amount of drugs that we use is low, and the length of stay is also low. So, yeah, we don't really know what caused the increase of price in those hospitals, but let me tell you that EFS is basically making everything more efficient. So, yeah, everything, the cost should be lower than here. Is that right, Dr. Jamat?
Yeah, I think it's correct, Dr. Yossi. Just try to start it first, and then you will find that all the time of surgery and also length of stay and also total cost will be reduced by itself. So never afraid of cost, but the problem is you have to do it more effort and also involve another specialty. Thanks, Dr.
Could I,
Yossi.
could I add a little bit to that?
Sure, sure.
Because we went through this same process, and the first thing we had to overcome was inertia, that the anaesthetist didn't want to change the way he did the anesthetic. The physiotherapist didn't want to come and see the patient the same day to get them up. They wanted to wait till the next day. And so they used any excuse they could to put them back to bed. So we had to overcome all of that. And so I think the main thing is to have a team of people that you have suggested who believe in it and who are really keen. And then it works really, really, really well. It's a great thing to do. And it is applicable in some degree to everybody. Not some very frail old people they're still a little slower, but they're still much better than if they're just left in bed for a couple of days, because they're much worse after that. So I'd strongly encourage you to do this. I think it's a really, really good system, but you mainly have to encourage those around you to want to do it as well and to believe in it.
Yeah, thank you, John. Yeah, our main problem in doing the EFS as well is if we get a different anesthesiologist, it usually doesn't work really well. So I think making a team is really, really important in doing, if you want to do the EFS program. Okay. Okay, is there any more question? Okay, please.
Yes, thank you for the opportunity. Thank you for the presentation about the IRS, because it's the interesting, it's the new. Because I want to ask how is what is the pitfall of the protocol of the IRS and how to solve that pitfall. And then the second one is what is the important thing about the IRS protocol, and in order to can apply it to another hospital. Thank you.
Okay, thank you. Dr. Jawad, did you get the question?
Yeah, Dr. Yossi. So I think the pitfall of the IRAS protocol, first, I think you have to, for the beginner, I recommend it to do patient selection very well. So try to start by using the simple one. For example, in THR, it's better you try to start by using the primary THR, the simple one. Don't use it for the revision or the complex primary totally. Just start doing by the simple one, like standard OA or standard APN. And also you have, like Prof. O'Donnell said, that you have to make a good team. So involve anesthesia, the rehab, nutrition, and also the surgeon. So this fourth team has a good commitment to do it, because like I said before, it makes more effort to run the protocol. So the rest of this, I think the people is very less, because it's only additional approach. Yeah, there is no difference between technical surgery. So only a small amount, like we do infiltration locally. So and then we avoid using the drain, and also avoid catheter, and also from the anesthesia also, the technical is quite same. Only maybe the dose of the spinal or epidural drug reduced according to the multimodal analgesia, like I said before. So I think the problem is how to make a team, a good team that has a good commitment to do run the protocol, and I think the rest is not so big problem, because I think there is no relation with the cost, no relation with the special or subspecial specialists will have to do it, but only the standard specialized can do it. Maybe that's from me, Dr. Yossi.
Okay, thank you, Dr. Jamot. I agree. Yeah, we don't need any special training to do the ERAS. We just need to enhance everything that we have. So basically, the ERAS element is already there. It's already been done. We just need to enhance it. And basically, what the ERAS do is mostly the anesthesiologist do the job, because the most important thing is the pain control and the post-op nauseous preventions. So if the patient is vomiting, if the patient feel pain, that it means that the EVAS doesn't work. So maybe that's the main obstacle in doing the EVAS. Okay, any other question? Okay, please, Dr. Vicky.
Yes, sir. Thank you for the opportunity. I will say thank you for the great lecture from the Dr. Jamot, Dr. Yossi, and Prof. Ardanal. Firstly, I want to ask, why the femoral derotation, especially Sugioka procedure, has less satisfaction outcome? Is there any artery or vascular problem during the rotation, or maybe is there any risk of embolization during the surgery, or maybe this is the cause of the failure is from the non-union case of the proximal femur? What is the cause of the possibility of this failure or decrease of the satisfactory outcome, sir? The second, from the AVN, especially FICAT 1 or FICAT 2, is it possible if we perform core decompression arthroscopically? And what should we do if we perform arthroscopically? We just perform the core decompression only, or also we can inserting the bone substitute or bone stimulating growth for the decompression, sir. Thank you, sir.
Okay, maybe I will try to ask the first question. Maybe for Ferdinand, maybe we can add something later, okay? Okay, for the first one, for the Sugioka osteotomy, which is usually done in the AVN, maybe in the AVN grade 2, where the collapse is a little bit, maybe grade 3, where the collapse is there, but it's the area is not too big, so we can still have some degree of the normal cartilage in the inferior portion. So it is the indication to do Sugioka osteotomy, but somehow the risk of the successful rate is only quite high in the Japan surgeons. Maybe because they were trained specifically to do that. Somehow we in the US, maybe in Indonesia, and maybe in Australia as well, we are not really well versed in doing that kind of surgery. And maybe the preservation of the vascular is still not as good as they did. Yeah, or maybe it doesn't work in our hands. Okay. Regarding the second question, maybe Professor O'Donnell will answer that more completely. But there is a good paper about the AVN published in, I think, in the GBGS about 1 or 2 years ago, that they they give the patient the combination of bisphosphonates therapy in the cycle 1 and 2, where the collapse is still not as big as they should be. And the outcome is quite good without any cold decompression, without any surgery. Just give the biphosphonate in desiccation. They have a good follow-up rate. They had, I think, about the 25 years follow-up. So, yeah, so it's a good paper. Then I think you should look at that paper as well. Maybe Professor O'Donnell, maybe to add something about the Sugioka and the hip scope with the cold decompression.
Yeah, I trained to do Sugioka osteotomies when I was in England, of all places. And when I started in practice, I used to do them. And I found it a very stressful operation, but in fact, one that worked very well. But I didn't enjoy it. And I was always terrified that it was either going to get a non-union or greatly increase the area of avascularity and just lead on to collapse. Also, although that didn't happen, I worried a lot that it would. And I think everyone worried a lot. And so now it's far more common just to say, what's the point? We'll replace the hip if it's that bad. In terms of what you do for AVN, I think it's far from clear what's the best approach. And because some of these get better by themselves. I've certainly had the experience of doing a core decompression on one side and not the other, and they both got better. So it's a bit hard to work out what is the effect of treatment and what is natural history, and to separate those two things. And so you have to read papers on operative treatment with a little bit of skepticism, I think. It's very hard to know how much of the outcome of the outcome is due actually to the treatment. But certainly people have talked about, or called arthroscopic core decompression. To be honest, I'm not quite sure what that means, because it's really a very small mini open operation anyway. You can look inside the hip at the same time as you're drilling to hopefully avoid perforating the cartilage. But you can avoid doing that in any case just by being careful using an image intensifier. You can then put the telescope down the hole in the femoral neck to see the area of avascular bone. Some have then gone and removed that either with curettes or with some form of expanding drilling device, and then packed that hole with bone graft substitute. So you're taking out some dead bone and putting in some more dead bone to replace it, but perhaps with some form of bone stimulation as well. And then various people have claimed that that works better, but I really don't know if that's true. So I was very taken with the idea of bisphosphonates as well, but none of these things are truly well worked out, I don't think. There's a lot of uncertainty about what is best. So the short answer is I can't give you a good answer. There are many answers and no one knows which ones truly work the best.
Okay, thank you, Prof. John O'Donnell. Okay, so is there any more question for all the faculties and speakers? Yes, please.
Okay, thank you for the opportunity, sir. I have a few questions. For the first one, for the ERAS, how do you select the patient? Is there any sort of criteria? And then for the second one is for choosing between the hip preservation or the hip replacement, especially for active young patients or let's say just athletes, which kind of procedure would you choose, with bearing in mind that the patient needs to return to doing the sports? And then for the third one of the indication for the hip arthroscopy is for the labral tear, as already explained before in the presentation that it was a very important structures. Is there any kinds of cutoff point? Let's say that does the measurement of the tear have any does the small tear, should we repair all kind of tears? I think that's it. Thank you, sir.
Thank you. Okay, maybe about the first question about the EFS. Is Dr. Jamat still here? Okay, maybe
Yeah,
I'll.
Dr. Yossi, but I lost my.
Oh, okay.
No, you repeat the
Okay,
question.
so the question about the first question about the EFS, how do we select the patients that is the ideal candidate for the EFS in the total hip replacement?
Okay, thank you. So for the patient selection, I think just like I said before, I think for just start using the simple case one. You can predict that the operation not more than 2 hours with a simple technique, simple implant, and also less bleeding. You can start by the simple one, and also try to get the fitness of the patient with the SA or 1 to until 2. There is no sign of infection, good compliance, and also the patient that not refuse, because we have to educate the patient and tell about the protocol first, and then if the patient agree to follow, because the successful rate also depends on the patient eager regarding the following this protocol. I think that's for me, Dr. Yossi.
Okay, thank you, Dr. Jamat. Yes, I add something. Maybe the main reason why we need to predict this duration of surgery is because when we're doing the EFS, the anesthesiologist will give the spinal anesthesia only. They won't give any sedation. They won't give any epidural if it is not needed. So the duration will be determined by the amount of the injected drugs. So they need to be precise how long the surgery will be, because we do not want to add something, add more medicine or drugs, anesthetic agent to the patient if it is not necessary. Okay, that's the main reason why. Maybe for the second and third question about the label repair, how much label we should repair, maybe Professor O'Donnell can answer about it.
I think not all labrums should be repaired, but it's because a lot of people have asymptomatic labral tears, especially as they get older. So we have to be a little bit careful if we're doing MRIs on older people and we see a labral tear, that we automatically want to blame that for the patient's pain. So we just have to be a little bit cautious and be aware that it may be just a coincidence. So not everybody who has an MRI with a labral tear should have it repaired. However, if someone is symptomatic and we believe that they have problems within their hip that can be treated arthroscopically, and part of that is a torn labrum, then I would certainly aim to repair all of them. The length of it doesn't matter, because that just means you might need an extra stitch or two, an extra anchor or two. So that's not an issue. What is an issue is the condition of the labrum, and if it's severely damaged and degenerate, then repairing it is pointless, because you end up just with some sort of mush. So in that situation, it's better to reconstruct labrum. So, but you wouldn't do that in someone older or already with a bit of an arthritic hip. So there are cut-offs, but I think in general, always aim to repair the labrum when you see a torn one, always, if that's possible. There was another just mention of arthritis, and when you do that, I think there's a couple of considerations, and it's tricky because arthroscopic treatment of significant arthritis is not highly successful, but then nothing is. So right now I have a 23-year-old soccer player who has a mildly to moderately arthritic hip. He plays at top level. He wishes to continue doing that. So I think if you replace his hip, he's not going to be a top level soccer player. So the discussion we have had is, can we get him sufficiently better that he can continue to play soccer for some time, meaning years, knowing that he will need another operation to replace his hip later, but hopefully when he's significantly older. And I think there is a place for that type of surgery. So we do that, but as a rule, we're not trying to treat arthritis with arthroscopy.
So the main answer of that, if there is any presence of arthritis, then we try not to do the hip preservations. But it is quite tricky when we're dealing with athletes because, yeah, as John mentioned, if you do the hip replacement in this kind of athletes, they cannot perform really well, especially if it's high contact sport, etc. Yeah. So, do you have any other experience with the athletes when you're dealing the hip preservation? Do you in the case that you need to replace them, do you need you try to replace them, or you just do something else in those patients?
We do both. So depends on this. So I can't give a single answer to that question. We aim, so it's something you discuss with them at some length. So the obvious one's the famous one was Andy Murray, the tennis player. So he had an arthroscopy. It achieved what he said he wanted, but of course, once he was better, he wanted to be more better, and he wanted to go and return to being a competitive tennis player. So he has a resurfacing now. So he's playing on that. He's not playing as well as he used to, but he's not doing badly, all things considered. So it's really hard to know what is the correct answer, and it requires quite a lot of conversation with the athlete about what their aims are and what you feel is the best way, most likely to achieve those aims.
Thanks, John. Yeah, it's also quite tricky if you're dealing with athletes. Okay, any other questions? Okay, maybe because of the time as well, it's already 12 p.m. in Indonesia, so I think it's time for me to end the discussions. And maybe thank you so much for Dr. Jamot and Professor John O'Donnell for being a speaker in our sessions today. And maybe next year we can meet in Indonesia as well, because we're going to have a hip and knee meeting in Bandung. Maybe if you like to go to Bandung, Indonesia, we'd like to invite you to go there, Professor John.
Excellent. Thank you.
Thank you so much. Yes. Okay. Thank you so much to Dr. Jamat as well. Safe flight for your flight. And I think yeah, thank you, Dr. Jamat. Okay, maybe that concludes our meeting. So I will give the mic back to the MC. Dr. Evan, please.
Let's give a warm applause to Prof. John, Dr. Jamot, and also Dr. Yoshi for the brilliant presentation and discussion. Dan selanjutnya, dengan berakhir sesi kedua HIP ini, maka acara sudah pada penghujung acara. Sebelumnya kami ucapkan terima kasih sebesar-besarnya kepada para narasumber dan moderator yang telah berkenan memberikan sharing ilmu kepada kita semua. Dan bagi para peserta juga kami ucapkan terima kasih atas antusiasmenya dan semoga mendapatkan manfaat dan yang sebesar-besarnya dari acara ini. Dan kami juga menginfokan untuk peserta dapat mengisi feedback dan absensi yang bagi yang ikut dalam acara offline bisa scan barcode, mungkin bisa di scan barcode di link evaluasi dan link absensi, dan bagi peserta yang hadir via Zoom dapat melakukan klik di link yang sudah dikirimkan di halaman chat. Dan sambil menunggu, kami mengundang, silakan, Direktur SDM Pendidikan dan Penelitian RSUP Fatmawati dan Direktur Media dan Keperawatan ya, dan kepada Ketua HKN Dr. Lydia dan pembicara atau moderator yang masih hadir pada pagi hari ini, siang hari ini, Dr. Faisal, Dr. Yosi, silakan. Dr. Faisal mungkin, silakan.
tulisannya Bu Dewi ada yang perlu dibacakan, Bu? Bu Dewi, ada yang perlu dibacakan? Oh, mana? Baik, terima kasih Dr. Erwin ya, Dr. Erwin ya. Terima kasih Dr. Erwin. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang, salam sejahtera, puji syukur kehadirat Allah Subhanahu wa taala. Kita tiba pada penghujung acara rangkaian seminar ilmiah yang diselenggarakan oleh RSUP Fatmawati dalam memenuhi kegiatan Hari Kesehatan Nasional yang ke-59 Kementerian Kesehatan Republik Indonesia. Pertama-tama tentunya kita selain sudah mengucapkan syukur tadi, saya mengucapkan juga terima kasih kepada yang terhormat Bapak Menteri Kesehatan tentunya yang sudah berkenan beberapa kali memberikan tapping acara pembukaan kepada Bapak Direktur Utama RSUP Fatmawati yang berkenan mengawal keseluruhan rangkaian seminar ilmiah yang diselenggarakan dari tanggal 3 November ya Dr. Lydia. Dan tentunya yang terhormat Direktur Medik dan Keperawatan Dr. Wahyu yang telah mengerahkan seluruh kelompok staf medik fungsional kita untuk berpartisipasi melakukan kegiatan seminar ilmiah yang memberikan, kita berharap memberikan manfaat yang sebesar-besarnya, menambah pengetahuan, sharing informasi, dan juga yang terutama adalah transfer knowledge tidak hanya antar provinsi, tapi saat ini sudah juga antar benua karena kita ada pembicara dari Amerika, ada pembicara dari Australia, ada juga dari Asianya. Kita kemarin mengundang dari Thailand dan juga dari Vietnam ya Dr. Lydia ya. Italia juga, Eropa. Jadi kita 5 benua ada semua ya Pak. Ada ya 5 benua semua. Alhamdulillah rangkaian seminar ilmiah yang diselenggarakan oleh RSUP Fatmawati. Seluruh jajaran direksi tentunya tidak hanya kita ada 2 direktur yang lain yang sangat berpartisipasi juga mendukung seluruh rangkaian kegiatan acara ini baik dari segi sarana prasarana maupun dari segi keuangannya. Dan oleh karena itu Bapak dan Ibu sekalian, kami juga mengucapkan banyak terima kasih terhadap seluruh kontribusi baik narasumber dalam negeri, luar negeri, internal dari RSUP Fatmawati dan juga tentunya mitra kolaborasi kami dari jejaring rumah sakit vertikal maupun rumah sakit lainnya. Dan terutama tentunya hubungan ini tidak hanya berhenti pada saat seminar yang diselenggarakan pada kali ini, tapi tadi sudah dinyatakan juga oleh Dr. Wahyu, kita akan mengundang beberapa narasumber nanti untuk menjadi perpanjangan dari kolaborasi yang sudah kita laksanakan pada hari ini dan kemarin-kemarin. Para peserta yang berbahagia sekalian, kami juga menyampaikan bahwa kegiatan ilmiah yang diadakan RSUP Fatmawati tidak berhenti, sekali lagi tidak berhenti pada hari ini. Kami juga akan menyelenggarakan berbagai kegiatan ilmiah lainnya, terutama khusus untuk ortopedi. Itu nanti memang kita mulai dari awal tahun, nanti kami sudah akan mengedarkan flyer pelatihan-pelatihan apa saja yang akan diselenggarakan di RSUP Fatmawati. Nah itu juga nanti bisa menjadi teman-teman sekalian bisa mematok kegiatan-kegiatannya dan bisa menghadiri. Seminar juga nanti kami akan melaksanakan juga mungkin kegiatan-kegiatan webinar berkala ya Dr. Wahyu ya teman-teman KSM, tidak hanya ortopedi tapi seluruh KSM yang memang menjadi kewajiban. Nanti Fatmawati juga ada pengampuan ya Dok ya. Nah ini dan juga kita mengundang untuk rekan-rekan semua terlibat berpartisipasi untuk melaksanakan clinical research di RSUP Fatmawati. Kami terbuka untuk melakukan kerjasama jejaring riset, clinical research maupun juga kita akan banyak melaksanakan Health Technology Assessment, sehingga para sejawat maupun mitra-mitra kita akan menunggu bagaimana kerjasamanya, karena kami terbuka untuk ikut dalam menjadi tim riset di RSUP Fatmawati. Sekali lagi dengan mengucapkan alhamdulillah, kami perwakilan dari direksi tentunya ya Pak ya, dan juga terima kasih Dr. Lydia, Dr. Yosi. Dr. Lydia, Bapak dan Ibu sekalian, adalah penanggung jawab ketua panitia HKN kami untuk penyelenggaraan kegiatan seminar ilmiah. Ibu Dewi sebagai manajer pelatihan, juga timnya, seluruh tim, juga seluruh para pendukung kegiatan, mitra kami semua, kami mengucapkan terima kasih atas segala dukungannya, sehingga alhamdulillah kegiatan rangkaian seminar ilmiah yang diselenggarakan oleh RSUP Fatmawati mendukung kegiatan Hari Kesehatan Nasional Kementerian Kesehatan Republik Indonesia yang ke-59. Dengan ini secara resmi kami tutup. Demikian, terima kasih. Wabillahi taufiq wa hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Mungkin kepada 4 petinggi Fatmawati yang sudah di depan bisa tetap di tempat dulu, Dok. Karena akan dilanjutkan foto bersama dengan peserta. Jadi mungkin para peserta yang bisa maju ke depan untuk foto bersama dengan panitia, pembicara, moderator, dan yang masih hadir pada siang hari ini. Mungkin ada yang di atas dan ada yang di bawah, atas panggung ada yang di bawah. Mungkin ada yang bisa di depan, dibagi aja, boleh? Yang laki-laki mungkin bisa jongkok di depan, jangan di atas semua.
aja lu cuma Fatmawati. Fatmawati pasti bisa.
Tes dulu, tes.
Telat kan?
Oke.
Telat nih, telat. Oke. Fatmawati belum.
Itu direkam, barusan direkam ya.
Fatmawati pasti bisa.
Ya, sekali lagi mengucapkan terima kasih kepada seluruh pihak yang telah berpartisipasi dalam menyukseskan acara ini. Kami mohon maaf jika ada yang kurang berkenan. Semoga Fatmawati selalu terdepan dalam memberikan pelayanan yang terbaik bagi masyarakat. Bagi para residen bisa tuh berfoto bersama guru-gurunya di Rumah Sakit Fatmawati. Setelah ini akan ada acara makan siang. Jadi makan siang prasmanan sudah disediakan di lantai lobi. Jadi bagi yang nanti setelah selesai acara bisa menuju langsung ke lantai lobi untuk makan siang bersama. Insya Allah gratis.